We'll be talking about advanced dermal filler in facial aesthetic. So it's very important to know how to do facial fillers and to understand from which they are fabricated and the type they are. I'm Dr. Nabil Faki. I'm a craniomaxillofacial surgeon and a facial plastic surgeon. I have fellowship in facial plastic surgery and rhinoplasty and owner and medical director of Faki Hospital, European Center for Plastic Surgery, and the vice president of the Spanish Society of Facial Plastic Surgery. So dermal fillers are substances used in soft tissue augmentation to enhance or replace volume that is lost in any part of skin or subcutaneous fat. So the history of fillers started from far ago. So they were using first paraffin wax injection with a lot of complication, then fat injection, silicone, collagen, which is in the 90s, then fat grafts for lipostructure, then polyacamide, calcium hydroxyapatite, polylactin, and hyaluronic acid, which introduced the last one in all these gamma. It's very important to understand anatomy and also to just know where vessels are because complication of fillers comes from injecting into vessels. Also, nerves are very important to understand. So, where you can block for making a nerve block, so you could make less pain treatments. Muscles are also important to understand how far they are from the bone and how are so thin from the skin and in which position they are so you could understand in which of these three depths you can inject under the skin, over the muscle, under the muscle, over the bone, exactly over the bone. So with anatomic dissection, you can learn how far also the arteries are from the skin and what are the routes for these arteries in the face so you could understand whenever you inject in the nasolabial groove, see how is the artery related to the nasolabial groove, or when you inject under the periorbicular muscle, how this artery is here, or beside the muscle dow, which the facial artery can go, and it's over the muscle. As you see in the nasolabial groove, how the arteries are related to with also relationship in the lip. This is the view of the dow muscle where the marionette lines. So see its relationship with the artery. So aging in the mid phase is very important because first you start with volume loss by loss of fat and there is bone remodeling and the skin will be thin and the muscle will start thinning. Then there is a loss of elasticity, lines increase become so permanent, and from this you start with skin changing with skin texture and dyschromias aging your face. Aging in the mid-face also, as you see how it changes, the most important structure is the fat. How much fat you have in the face, how much volumized face you have a rejuvenated face. Remember that for blepharoplasty, for making eyelid surgery, uh, some years ago they were taking these fats, but nowadays no one takes these fats. What they do is fat transpositioning to another area to improve this. It's very important to understand the Auger curve. The Auger curve describes the curve from the cheekbone to the mid-face hollow. The goal of mid-face enhancement is to restore the Auger curve. This is a very nice picture to let the patient understand how you can voluminize this area and change it from a positive vector to a negative vector. Restoring the Auger curve is for more youthful look. It was published in 2011 by Swift and Rimler. Also, it's very important to understand the malar areas. Some doctors think that the malar is only this area, so the malar should continue with the maxilla area, which is the anteromedial cheek, and the zygomatic arc is where it continues this anteromedial cheek to improve it and make it nice. And the submalar region is very important just to improve its volume by injecting subcutaneously in patients who have a lot of loss of this area. As you know, there is buccal fat pad removal, which enhance if you remove the fat from this area to make your cheeks more hollow. But in these cases, in patients who has volume loss, sometimes injecting in some malar region improves this effect, making the crease to be so nice, and then improving the cheek aspect. Remember that it's somehow nice to have a bit deep in this area, a bit, not too much. As you see here, I'm writing inject subcutaneously, inject whatever. Forget about this because you cannot inject only what it says in here. Sometimes you have to inject superiously, sometimes subcutaneously to improve something. We will learn that more when we go in the presentation. So it's very important uh, by when you age that all these things around your face will start having affected by elastin loss and making you older. I will not go in this presentation since you can read it and you can understand that the changes of the face. So for a more youthful look, uh, they have seen that after you inject fillers at 6 months, they see themselves 5 years younger perception, and at 24 months, 3 year younger perception. So typical area to use hyaluronic acid is everywhere you could improve an area with loss of volume or there is a loss of uh, elasticity and you have a depression and you want to correct it. Also, you can use hyaluronic acid not only to correct volume loss, to improve certain areas with some types of hyaluronic acids, which are doesn't have a lot of material and it's more diluted and with less concentration to improve collagen. So the classification is divided by longevity, site of placement, and origin of filler material. So for the classification, we have several types of fillers. We could have biodegradable one, which are less than 1 year, semi-permanent from 1 to 2 years, and permanent more than 2 years. The most famous one is the biodegradable one, which is the hyaluronic acid, and we could have from avian or bacterial. Nowadays are more bacterial and they are not using avians. But also there is collagen, which is from porcine or human, as we have in here in the presentation. The advantage that they disappear and it's temporary. But also the effect is if it's unacceptable, you know that it will change, or there is in case of hyaluronic acid, days to eat these hyaluronic fillers. So collagen was used a lot of years ago, but the problem that they only last for maximum 6 months, and you have to re-inject again. Semi-permanent, as calcium hydroxyapatite, they are like for 1 to 2 years, or polylactic acid. Uh, just in fact, they are undergo slow degradation within time 1 to 2 years, and As you know, they are commonly used nowadays. We will see it later. Whereas permanent one, as silicone or polyacrylamide, in fact, in my ethic way of thinking, I think doctors should not use these materials, having materials are biodegradable and without any future problems as cysts and complications. So the site of placement, it depends if it's dermal, subdermal, or superficial. But in fact, sometimes you have to go like under the epidermis or dermis superficial, or sometimes deep dermis, and also sometimes you have to go for the subcutaneous, and some few times you have to go over the bone or under the muscle or over the muscle. So the classification should not thinking if, oh, I'm injecting dermal, subdermal, superficial. It depends sometimes what you want to correct, and you go from this epidermis till the bone, depending your way of making the solution. The one the area you want to treat, so you have to diagnose it and see how much volume she needs. Normally, if you want to enhance an area, you can go in an area that is bone, you can go over the bone. But sometimes enhancing so far, putting fillers so far from the skin. So if there is a depression here, which is related to a bit of filler under the skin, you have to go more superficial to improve it, or put a lot of material in here. So that's why you have to think where I should put this to solve this problem. I will explain later. So also for the classification, you could have uh, human fat using as autograft, as autologous fat from liposuction. As you see, there is a lot of materials and site of displacement and longevity and injection technique, and if it's FDA approved or not. But in fact, what you have to learn from this presentation is that you have to use hyaluronic acid, and or the other option is using fat, patient's own fat. The problem with using the patient's own fat is never use it in a patient who is his first time he wanna does lipofilling. Try to convince him first to do with fillers for the first year to see how he can change, and if he like the result, go for fat lipofilling. The second thing, that sometimes some patient doesn't like to the overdone maybe, and with fat you could go, sometimes you have to overcorrect because you know that a bit will be absorbed or reduced. So always explain to the patient that fat it's not so meticulous as fillers, because you can go increasing a bit and bit. In fat, it's a surgery, you have to go there is inflammation in, and sometimes it's this overcorrection, it loses a lot, and sometimes not, you have to redo. So I usually explain them that it's for one procedure for life, but sometimes you need to do some retouches. Whereas fillers is you have to, it's no downtime. There is as liposuction, but you have to inject me every year and a half every year. So types of fillers, we could have autologous fat, as we have seen that uh, it's unlimited and it's a generous donors of volume. Theoretically is permanent, but there is some natural loss from it, and also it's does not require any treatment in the future maybe, or you have to do some retouches to increase it a bit. But the other problem is fat grafts are unpredictable. The other one is dermatologen, is one of the brands, but it's collagen. It's, remember that instance fillers. It's for 6 months stay, and beware of allergic. You have to do tests when you're using collagen, tests for allergy, and because sometimes are human animal. The calcium hydroxyapatita, so as radiase is one of them of the brands. It's an organic substance, and this filler promotes growth of collagen. It provides fullness to the skin and fills wrinkles and folds, at the same time provides a lifted effect to the skin. So they say it, oh, it's the double effect, lift and full as radiase cells itself. Sculptra is also, it's not a filler, it stimulates collagen. It takes about 4 to 6 weeks for the effect. Remember to tell the patient that when you inject Sculpta, okay, you will get some volume, but this volume is simply it will go out in a week, and the result it's for trying to see it is around 4 to 6 weeks effect. Usually it takes 2 to 4 sessions to achieve full correction, and it can last 2 to 3 years. It is only a stimulatory effect, varies from individual to individual. Belotero or other hyaluronic acids as Juvederm or Restylane or Belotero, it's a complex of sugar which we will see abundant glucosamine, and it's in the human dermis, and it started by using the humeral vitreous from the eye, taking these concentrations and trying to use it for ophthalmology. So for permanent fillers, I say no, never, never. Think twice before you ask your doctor for a permanent solution. I said I let the patient see this. Forever is long, but it's long, long, long time. So never use permanent fillers. I think it should go on ethics, and if you go to ethics you have to help patient, not let them have a problem in the future. So as we know, all permanent fillers gets problems infection, or capsula over the silicone, or extrusion. So please don't use these permanent fillers anymore. Hyaluronic acid is a substance we already have in our body. It binds to water and gives firmness to our skin. And it's natural, so use that. So in 1934, Mayer and Palmer first isolated the hyaluronic acid from bovine vitreous humor. In 1970, it was first used therapeutically in human medicine and surgery as the first product containing hyaluronic acid for the use for ophthalmology and traumatology. Then, Biomatrix developed second-generation hyaluronic acid derived from halons through cross-linking, making it more stable, then increasing the tissue resiliency. Then in 2000, the introduction to aesthetic market increased, and it's everywhere. So as you see that the most abundant glucosamine in the human dermis is this area, skin. So sodium hydronate is the key water-maintaining substance in human skin, and its ability to hold 1 liter of water for a gram of hyaluronic acid. So you tell me why I should know all this information for treating fillers. Yes, it's very important to understand what material you're working with, what it does, what its advantages, disadvantages, and how can I solve complication. In medicine, it's injecting fillers is simple. What's difficult is to treat complication, to avoid complication, and to understand from where is materials. I always ask a lot of doctors who inject fillers from what fillers is made. They don't know. So, or what does filler do? They tell you, okay, it fills water in it. That's not like that. So as you see, is a complex of sugar and found in cell surface and extracellular matrix of the skin. And in the vitreous humor of everyone, there is 0.1 milligram per milliliter. So also there is other parts of the body which we have this hyaluronic acid. The good thing that it has a similar chemical structure and is identical in all species and tissues. This is a very important point. So that's why we could use hyaluronic acid from other species. Thus, it's non-immunogenic, found in all vertebrates and synthesized by some bacteria. Which bacteria? We will learn that. So it's the ideal biomaterial substance for use as a filler and highly hydrophilic, loves water. Water comes to it and rapidly metabolized in the body around 0.5 days to few days if I inject hyaluronic acid without stabilization. So the unmodified hyaluronic acid has a half-life in the body around 24 to 48 hours. So that's a very important point. So stabilization increases the length of time. So that's why they stabilize the molecule doing cross-linking. It's very important to understand the point of why we do cross-linking. So modification should be minimal so the body sees the material as native, and also hyaluronic acid must be cross-linked to stabilize. So all that what we have seen. The next step is the function. So it's the function of hyaluronic acid. It's an important component of extracellular space. So it maintains proper structure and tissue functioning by what? Creating volume through high water binding capability, protecting and lubricating tissue, joints, tendons, affecting cell integrity, mobility, and proliferation. Also, it's good for transportation of nutrients to form cells. So this hyaluronic acid is very important to the skin because it maintains the volume and the viscosity. Also, this hyaluronic acid should decrease with time, so we need the replacement of these. The average concentration of hyaluronic acid in the human body is 200 milligrams per kilo. The large distribution of hyaluronic acid is where? In the skin. See, 56% of our hyaluronic acid is in the skin. The rest is in the connective tissue, then muscle, then intestine, and others. So sources of hyaluronic acid. First, they were from rooster comb, from the male chicken. Yes, used earlier and now only for non-aesthetic. But for aesthetic, they are using two bacteria, the Streptococcus aureus or the Bacillus. So, what's the difference between them? Let's see and let's understand why there are types of in the market of fillers. Others are cheaper, others are better, and they tell you they are better. But when you go to buy a filler, you never learn from where it comes. So that's very important to understand that, and you can ask. So, Streptococcus aureus is a pathogen in horses. So the uronic acid is produced by the cell and surround the bacteria capsule. So cells should be disturbed to secrete the hyaluronic acid. We will see it later. So there is a bacteria which secretes hyaluronic acid. So to take out the hyaluronic acid, I should rupture the cell. This bacteria, I should kill it and take out the hyaluronic acid. So we use organic solvents to separate this hyaluronic acid from the bacteria's cell surface. So you're using some organic solvent. Disadvantage, there is residual trace of endotoxin and lack of uniformity in the hyaluronic acid molecule. Whereas Bacillus, it's a new source started in 2011 and for aesthetic market, and the advantage, it has a lot of advantage over Streptococcus. First, this Bacillus secretes the hyaluronic acid in a narrow range of molecular weight. So, and the chain length has more uniformity in the final product. So what the good? We don't need these organic solvents to rupture the cell to get the hyaluronic acid because they secrete the hyaluronic acid. Also, the disadvantage is some residual traces of endotoxin and lack of uniformity in hyaluronic acid molecule in some bacteria when they started doing. But now they try to improve this and trying to let just take the hyaluronic acid secreted by this bacteria and to stabilize that. So, as you see, when they stabilize this, the streptococcus, the bacillus fermentation, it has more homogeneous hyaluronic acid strands when they try to improve these bacillus problems. So now, as you see, the streptococcus will try to we have to rupture the cell to get this hyaluronic acid. So we have less homogeneous hyaluronic acid. Whereas this bacillus secretes all of the same hyaluronic acid. So this bacillus will get no need for organic solvent to recover hyaluronic acid, and these subtype strains does not produce any endotoxin, and they are so homogeneous. So nowadays everyone recommends these. But still in the market, there is a lot of streptococcus fillers. The second thing you have to know is about cross-linking. G prime, viscosity, concentration, and cavicity. So they tell you, oh, try to use these fillers. And you say, what is the G prime? What is the cross-linking? What is the viscosity? They tell you, I don't know. They don't know. If they don't know that information, they should not sell fillers. Oh, I can get you from the lab. And if you want to sell, you have to talk about these. So cross-linking, the uncrossed link of hyaluronic stays hours in the body, but if I cross-link it, it makes to degrade less. So how much more cross-linking, how much more stays in the body. So That's why the uncrossed link of hyaluronic acid works as lubricant, but the free crossed hyaluronic acid works as a gel-like material. Only way to achieve durability is to make it more crossed. So every brand lasts more than one since they are more crossed or less crossed. G prime. G prime represents gel hardness. So it's measured by placing a specific amount of hyaluronic acid product between two metals plates, then measures how much force it takes to slide one plate against the other. It's very important. Higher crosslink, higher G prime, and vice versa. So whenever I crosslink, I need more power to move the gel. So Restylane has more than Juvederm, more than Belotero. So the gel in Belotero is less hard than Restylane. Viscosity is measured the force required to push the product through a syringe, and is directly proportional to the G prime. So higher crosslink, higher G prime, higher viscosity. Also that I need to press a lot more in the syringe of Restylane than in the syringe of Belotero. It's very important the pressure when you inject filler, since how much more pressure you have, much more less you control injecting, because you cannot feel how much it's getting in. Anyone who injects fillers, he may understand me. So concentration, it's also important. About effective hyaluronic acid concentration. Effective hyaluronic acid equal to total hyaluronic acid minus non-cross-linked hyaluronic acid. This is the effective. So you have to ask always for how much effective concentration we have in this range, not how much concentration of hyaluronic acid we have. The other thing is cohesivity, product ability to retain its shape on injection. So cohesivity expresses the amount of pressure required to press two plates together like a sandwich when a particle HA product has been applied between the plates. And it's very important to retain shape, since Belotero retains more shape than Juvederm, more Juvederm than Restylane. When you inject, sometimes you make massage. This massaging just let the filler move and adapt, and how much retain in shape it has, how much better it stays in the area. So viscosity and elasticity, as we have seen, you could see these numbers between difference between the in the market. As you see, it has a lot less elasticity and viscosity below there. So the ideal filler is hyaluronic acid, and the ideal filler is everyone would love to have a long duration, persistent, also with painless procedure, non-toxic, non-inflammatory, non-carcinogenic, non-migration, non-animal origin, easy to inject, easy to store, ease of learning how to inject, minimal side effects, all strategies of injection, to be biodegradable, all these stuffs. So all these things, the ideal filler. But nowadays we have different types of in the market. So we will learn in this presentation what's the advantage of everyone. So the indication, you can fill, as I've seen, anything you would love to improve the area of depression. Contraindication. So for hyaluronic acid, no need for positive test testing, but for collagen, yes. Patients with autoimmune diseases, we have to take into consideration some reactions more with collagen and these stuffs, history of serious anaphylactic reaction in the past, active local disease like acne, try to avoid injecting in these areas, keloid tendency, beware because you can make a keloid from the injection, and unrealistic expectation, always this patient never treat them. Caution should be taken in some conditions. History of facial herpes simplex, if there is, just give him a cyclovir treatment for 1 week to 2 weeks before the procedure. Few doctors do this, and normally a lot of us have herpes simplex. I'm a doctor who has history of facial herpes simplex, and mainly in winter. I got 1 or 2 times. My wife never had any problem with this herpes simplex, but I've been using filler on myself and never tried to take acyclovir before my fillers. And what it could happen, just beware. Ask the patient always if he has facial herpes simplex, and always cover yourself. History of any atopy, history of bleeding disorder, or use of anticoagulant like aspirin. Patient who use aspirin, tell them to stop it 10 days and come back to you, because they can have more risk of having hematomas, if they take coagulant things or whatever. So current or long-term use of immunosuppressive therapy, also beware of these patients. So filler market is increasing, and it's every time has more revenge money, and it's injecting a lot of money to the market. So because there is a lot of people want to fill areas, and now they are more understanding how much important is the volume loss of the face, and they see themselves older. As you see, there's a lot of brands. I will not go in it. There is like Aquamid, Atlian, Allianz, Emerval, Evolance, Novabel, Revavil, Redixi, Successive, Deusal, Varioderm. Well, as you see, there is a lot. All these things I've said, I think they are poor, cheap fillers with a lot less studies, and there is nothing uh, solid. I will never use them, whatever it costs. I think the only thing you could use in your office, if you want to use good fillers with good materials, use Restylane, Juvederm, and Belotero. Only the three are acceptable in my philosophy. Whatever it costs, whatever promotion you could have, use only good things for your patients. This is ethics. Medicine is ethics. So avoid using cheap fillers, which was not solid studies. Whatever country is fabricating it, they always tell you this is an Italian one or whatever. Only use these three. So we will learn only top brands and the differentiation between them. So I have been using the three types, and from everyone I have learned something, and from everyone I have its positive thing and its negative thing. But from 2 years, I'm only using Belotero because I think, and I will explain it, all the advantages it has over the others. The first one is Restylane. So Restylane is very good one. It's a pure one. It's the first one. They have a lot of studies, and maybe the most solid studies, and a lot and published articles on this brand. So we have Restylane, Restylane Volume, Restylane Sub-Q, and Restylane Perlane. As you could understand, Rustylane is used for these blue lines. As you see, we could learn that they have four subcategories. Rustylane. The first one is the Rustylane normal. Sometimes it's Rustylane L, which L means lidocaine. Okay, let's there is Rustylane and Rustylane L, and this Rustylane is like the soft of others. This is soft. We will say that nowadays soft is for areas we need a little of improvement, like lip, small areas improvement, and nasolabial sometimes, and under the eye sometimes. If there is not a lot, there is no deep area loss. So in these areas, you have to inject something soft. Then I will say medium for areas which need a lot of improvement. Sorry, I mean middle improvement as cheeks, nasolabial groove sometimes, or uh, sometimes angles, or chin a bit, or nose. Sometimes I will say a lot, which is soft, medium, and a lot, like for cheeks, for chin improvement, and for areas we need a lot, temples. This is like a lot, you need a big volume. So we'll say soft, medium, and big volumes to let you understand. This is like the soft one. The Restylane lip, they made it for the lip, so it's very important to enhance this area in the lip because they need like more than the first one. It's like somehow soft to medium. And then we have Restylane sub-Q, which is hyaluronic acid, which is volume, and it's used for for the malar and for the chin. It's for telling you, okay, this is a strong one, a lot of big volume. And then we have Restylane Perlane, which is for telling you medium to big. So if we go back for the four, we could say that this is soft medium, this is strong, big, and this is, could say, medium to big. So you could always use Restylane for the lip also without having Restylane lip, and you could use also Restylane Perlane for the cheek without having Restylane sub-Q, although sub-Q gives most volume. Mainly the hyaluronic acid is 20 milligram per milliliter of hyaluronic acid of all the product. So again, you can read these at your home and learn more about the difference, and for every area you should be treated. Also, there is Restylane Vital, which it's like suitable for patients who have mature skin, some damage, and this product is like a skin booster. It does not give a volume. It only hydrates. You can inject it as a mesotherapy in face, lips, hand, neck, and recommended 3 sessions with a space between 1 month. So these patients are Restylane patients, and just to let you see the effect from the volume and to understand what you can do. Remember that fillers improvement and being perfectionist needs sometimes more volume, and the patient cannot pay a lot volume. So you should understand there is limits for patients before and after. And some patients they are not so wow since the patient cannot afford more syringe to pay. So this is the result we have. In this patient, she wanted improving only of the skin by Restylane, and she used Restylane Skin Booster, which it improves a bit. So this guy needed treatment for the cheek, tear through, forehead, and sad mouth corners. So they have used Restylane Vital, which is the skin booster for all the skin. 1 milliliter of Restylane for the tear through, and 2 milliliter of Restylane divided to the sad mouth and some forehead area and some cheeks. As you see, there is a bit of improvement, and this bit of improvement is what sometimes patient wants. And we have used a bit of Restylane, normal one, to correct this one. This patient of Restylane company, as you see, they used Restylane Vital to improve this skin area. From here to here, you could see a bit of improvement, and also you see 1 milliliter of Restylane. She wanted to correct tear through, lip line, cheeks, forehead, and sad mouth corners. So the forehead she used the Vital with all the face. The sad mouth corners they used Restylane for this and tear through, and for Restylane Perlane for the cheeks, and for the lip they use Restylane volume. I will not talk about everything, but just let you see results using Perlane to improve the nasolabial folds. As you see, you can improve more. You need more syringes. Maybe you cannot pay more. Also this, and you could see there is improvement. And see, normally they use like about 3 milliliters. I hear a lot of patients using only 1 milliliter to enhance the face. You cannot do anything, and with 2 milliliter to enhance the face is still a little. Minimum to enhance a face you need 3 milliliters and up. So this patient also, you could improve his tear valley in here and a bit of his tear through more, but they use 4 milliliter of Perlane. I would be using here more the Restylane Normal, the soft one, to improve this area. So I will not go for all these patients of Restylane, letting you see them, but just to go sometimes also to understand this patient. Sometimes, as you see, they corrected the cheeks, and when you correct the cheeks, you correct sometimes the eye, the teeth through, since giving volume to this a bit to this area will camouflage the transition from the deeper one to more upper one. So that's why this patient, she uses Restylane Perlane 1 milliliter to improve the cheeks a bit, and the other Restylane to improve lower cheek, lips, marionette lines, and bit of the cheeks. This used only for neck decollage, face the skin booster. Sometimes it's very hard to see a lot of difference, but you could see the difference between. So that's why it's very important to take photography to let him see before and after. So the next one is Juvederm. Juvederm started with these brands by selling Hydrate, then selling Juvederm Smile, Ultra 2, Ultra 3, Ultra 4, and also by Voluma. So these, there are some countries who are still selling these, and you have them in the market. This is the first gamma of Juvederm. Juvederm has made different gammas, and I will explain them. Then there is another gamma, which there is Voluma XC and Juvederm XC, only two, and mainly are now are the, I could say that maybe 60-70% of the market have these. And the difference between both of them, that Voluma is to volumize, which I can say big volumes, and Ultra C XC and Ultra Plus XC for lip and for soft. So we have soft, medium, and big volume. By again, they made another study and they started to make new crosslinks, and they made the VY crosslink collection, and it's Volbella, Vollift, and Voluma with lidocaine. So what's the difference between all these Juvederms? There's a lot of three times they go to market with three different things. The first one are the normal hyaluronic acid. The second one are the Helacross. The Helacross, which is the Voluma and the XC technology, which is robust and smooth consistency. And they have seen that they made hyaluronic acid, the cross linkers, and now they have the highly concentrated cross link. So they added the solution, and they added with a liquid solution with lidocaine. And we have, this is the Juvederm, which is immunized, and this is the Juvederm XC with 0 to 3 lidocaine. So this is the difference between both of them, but also Juvederm has greater resistance to degradation than Restylane, since they are more cross-linked. And as you see, the hyaluronic acid of Juvederm is smooth consistency, but still with granular under the microscope, some granules, where competitive hyaluronic acid, it's more granular consistency. So the Helacross, as you see, which is the Ultra Plus and the new ones, it's a cross-linked high molecular weight of hyaluronic acid, lasting result with lifted provided primarily by cohesivity. But as you see, the new VY crosslink, it's like tightly cross-linked with low and high molecular weight of hyaluronic acid. So this gives more a lift provided by tailored G prime and cohesivity, giving a better effect and stability. Also, these V-Cross products are associated with minimal gel expansion, which is the things the doctors would love, which is okay. Now what I inject is what I will be having exactly, and this is like more constant the volume change. As you see in the Ultra Plus with lidocaine, we have, which is the one which have in the market. These are like new from 1 to 2 years ago, I think so, and now they are getting more known, and now they some doctors they having them in their offices. And as you see in the other one, there was an expanded gel like that, a remaining water, and this is hyaluronic acid. And as you see with the new one, they take it out the expanded gel, so the uncrystalline gel swelling is in the Hyla cross is more than the V cross because they have more expanded gel. So this V cross, it's a unique formula, which the second generation is the Voluma XC, and the XC has this view has improved this for the new one, which is the Volvella, Vollift, and Volume. Also, Juvederm range of fillers uses property technology, as you see how every time is more cohesive, and the VY cross is also more smooth than the HLA. So from here they are learning to improve the technology and to have like um, more refined one. And for study of Juvederm, you could see how much it stays. It's like percentage of patient with clinically significant improvement, and in 24 months. Also, the VY cross collection, you could see that a difference between Volavella, Vollift, and Voluma, that we have the packages also how much millimeters, but you see the concentration is around 15 to 20, which giving more volume in here, less volume here, and the syringe which comes with it. It's very important to know how much volume is increased. You cannot inject sometimes in a small syringe 33 or 32 because you cannot get the filler from it. So to go more for this versatility of the VY Cross collection, if we compare between Juvederm Ultra and Ultra Plus and the new one VY Cross one, you see that they have less concentration, more G prime, less cohesivity. So for the Juvederm XC or Volbella, you could use it for lip, for vertical lip lines, nasolabial folds, or a commissure or marionette. Everyone could have a complication as redness, formation, whatever, but these the studies of Juvederm between them and other ones, the Volalift and Ultra Plus XC, it's used more for nasolabial fold, oral commissure, and marionette lines, and the Voluma and the Voluma XC is more for zygomatic arc, anterior medial cheek, and smaller region. So also they have Juvederm Hydrate, which is full face and neck and hands. It's a skin booster mesotherapy treatment. So also it's very important to see how by Juvederm XC the correction and 1 year before and after photos. And as you see, this is before, this is after one syringe, we could improve. This is with two syringes, we could improve more. And after three syringes, natural force and were treated also, and there is a lot better improvement. As you see, the eyes, the other area, after 1 year, there is also again starting loss of things, but there is still stimulation of the filler, and it still has volume. These patients from Juvederm, as we see, just to learn that you could treat areas with 2 millimeter volume XC, with the treated for zygomatic arc, for the anterior medial cheek, and some malar region like this area. She had some loss here. She has these lines in here, and they treated it and see it very nice correction. As you could see, there is somehow flat the OG curve, then you have here a good corrected curve. This other patient, 4 milliliters of Voluma XC for zygomatic arch, anteromedial cheek, and some malar region. Uh, Sometimes these patients in pictures, you see them like that, and you see, oh, she doesn't have a lot of loss of volume, but when you see it from the lateral side, you see a lot of less. As you see, it's very important to correct anteromedial cheeks because it's somehow off and makes this area be less deep. This is needed 3 milliliters of Volumax C. As you see, it requires a lot more syringes to improve other things. This is also, you got an improvement, but she has a bad skin. She could improve also other areas as nasolabial groove or lips, but this are 3.5 milliliters for cheeks, and you see there's not a lot of difference sometimes, since as I recommend, I usually use for a patient who want to improve his chin, his cheeks, and he has depression, minimum one to 1.5, and sometimes I'm somehow I need more syringes. Is it the OG care? This is another patient who comes to give them for nasolabial folds changing. It's very important to learn from the company's patients and procedure so you could understand how much product they put in and what they want to correct. As you see, they corrected the nasolabial fold. There is improvement, but you can always improve more. You need more syringes. Also, mediated lines and oral commissure, you can go and improve it a bit more. And zygomatic arc and anteromedial cheek and some malar region. As you see, they used like 8.5 milliliters of uronic big volume, and with these using big volumes, she got an improvement, which is a lot better, but still needs some improvement. This is very important to understand the patient. Let him see that some patient consumes 10 milliliters of syringe to improve his face, and others not. But there is a very important improvement. She still is the same, but she has a nicer effect. This is also, she had a lot of depression in the cheeks and needed, like as you see, we have like 10 cc's or more for improving all these things. Also, this patient of Juvederm, as you see, she has some improvement. So to go for the star, which I love that filler, I could say that Belotero, when it got to my clinic, I started using it. I started falling in love with him because he has a lot of advantages to others, and also as you could see, it's the injectable product of the year, and it has skin hydration. The good thing that they have 5 gammas, five subcategories, and by this you could play a lot to improve areas, which you can have hydro for mesotherapy, soft for small things, balance to balance things, intense to give volume a bit, and volume to give a lot volume. So the good thing of this family of Velotero that it's they have different hyaluronic concentration, and you could go for improving a lot of different things in the face and be in the safe side, not using more volume because you have only 2 or only 3 types. So for Velotero Hydro, you need, it's for quench your skin thirst. So the good thing that you have to use it like uh, to make 2 3 injections, initial treatment phase between 1 to 2 months, and then you make maintenance phase. So it's very nice. You injected epidermally, leaving some in the epidermis. When you inject this, you see the patient with a lot of bumps under the skin because you injected epidermally or dermal superficial. These all will reduce in 24 to 48 hours. So injected like this to enhance the skin. And don't fear about these lumps. Then Belotero Soft are for treating very soft areas like crow's feet or some thin areas under the skin. You could do blanching with this, which this is an advantage of Velotero to others. With others, you cannot do blanching. Blanching means that you can inject under the skin and whiten the area. With Velotero, if you do this, you will not have any Tyndall effect nor any complication. With others, beware Tyndall effect, because Tyndall effect means that they become bluish. So that's why it's safe, more safe Velotero. Another thing which is very important for this is to understand how much you can go for that. And Belotero, the good thing of it that when you start using it, you always fear to overcorrect. Belotero is so say that overcorrection with Belotero using one syringe to treat, let's say, crew's feet. For this, I may use with soft maybe one syringe to improve all these four. And I still, as you see, with one syringe, you get more improvement you need. It's safe because sometimes you need more material than the others, because the volume is so specific, and I love that. For lips, I use Belotero Balance. It's the best for lips and under eyes. When you see the Belotero Balance, as you see, there's improvement, but only they used one syringe. And in this patient, they use maybe one syringe and a half for contouring. Mainly, all patient needs, if they need a bit of improvement, they use one syringe. If they use medium improvement, you have to use two syringe. And if you want to overdo it, you can use three syringe. But I never have used more than two syringe in the lip. I prefer natural results. Just always tell the patient that it's very good to go for improvement and not overdone. and and you could hear me, oh, you use 2 milliliters for a lip. Yes, this lip could admit 2 milliliters to have it natural. Remember that this picture maybe is with after injection and she has some inflammation. For Belotero Intense, you could go for lips. And some people who have extremely thin, never recommend Belotero Intense for lips, since I love more the balance. When you touch the lip with the balance, it's so soft, it's so as if you don't have any filler. Whereas if you compare to other doctors who inject with other materials, you touch their lips and it's so tough. So this is the good thing of Belotero Balance. You tell the patient that if someone kisses them, it's so natural effect and aspect, and it's not somehow hard as others says with other fillers. So for intense, I leave it for nasolabial groove, or some cheeks who are not so overdone, or they are good but they need a bit of improvement. You use Belotero Intense. So volume, I use it for cheeks, and mainly I use 1 milliliter for every cheek. In some patients, they need 1.5 or 2 for every cheek. If you want to treat paranasal, arc, and the submalar. As you see that I've been using for 2 years Velotero Balance. I inject myself Velotero Balance, and I have it in social media. So this is correcting tear through. And these patients are some of Velotero Balance, as you see after injection, because a lot of my patient doesn't come back for pictures. They are happy. So as you see, I injected in this patient. She has big cheeks and she doesn't a lot of need improvement, and I injected 2 milliliter, 1 milliliter in every area. And I can tell you that with this inflammation is good, but maybe she needs more 1 milliliter in this area. As you see, she has facial asymmetry. One is better than one. So tell the patient always that there is asymmetries in the face, and you have one eye more upper than the other, because they come back and telling you that they have one cheek upper more than the other cheek. And this is why, because they have the bone different to the other bone. So as you see, you could improve the area. Always massage. This is done by needle, but nowadays I do a lot by cannula, and try to leave needle for specific case. As you see, there is inflammation. I improved this area, not this area. She had this area from before. As you see, there was in fact as you see, a mountain, then a valley, then a mountain, then the valley of the nasolabial groove, and I did it one mountain. As you see, it's all one mountain compared to the other side, which I did now treat it. As you see, this is another patient which I treated. He has so flat in this area, and I marked by this. I will explain later. But as you see, he needed improvement, and he still didn't improvement. If you see, but he wanted only to pay for 2 milliliter of intense. I recommended 2 milliliter of volume minimum, but he didn't want to pay for volume. He has only for intense, and as you see, there is an improvement, but he can go for more to improve it. This is exactly after injecting. There's some inflammation. Remember that with balance and with Pelotero, you lose a bit, like mainly I could say 15%, 20% from when you inject of the reaction you get. So like this, I try to control my patients. This is another patient with a lot of facial loss. We injected 3 milliliters of volume for the cheek, for the anteromedial cheek and the submalar region, and you see with 1 milliliter and a half in this, and 1 millimeter and a half in the other, she still needs some improvement to improve this area by balance a bit, and a bit of improvement in her cheeks to give it more that. For her nasolabial groove, I also used 1 milliliter in every area, and she's improved, but she still needs a bit more. But she doesn't want to pay a lot. She also came back, which I don't have the pictures, for improving her lip, which, but you see that she has good volume, but she needs a bit retouchment to improve it more. This patient come for only improving her cheeks with 2 milliliter. As you see, the volume loss in here and the improvement positive vector. She has bad skin also. Also, this patient came for tear through. For tear through, beware so well, because this area is so difficult to treat it. You have to have experience. So first learn when you want to start on the cheeks, then you learn on the eyes, and other areas are sensitive. For this, one recommendation is to inject under the muscle, always under the muscle, always, always. So leave it for over the muscle for very specific cases. So I could inject 1 milliliter under the muscle here and 1 milliliter under the muscle here, and I get some improvement. But now, if she want more improvement, maybe she needs a bit, 1 milliliter under this and 1 millimeter under this. But as you see, if we go for that, she needs like 0.2 to 0.3 millimeter under the skin by a bit, just to give it and enhance the undersurface of the skin. This patient also came. This is a post treatment, and we improved from this to this by 3 milliliters, 1.5 and 1.5, and he still need like maybe 1.5 for both eyes to improve it for maximum. The balance, if you inject under the muscle, is so safe, so safe. Whereas if you inject under the skin, it's safer than all the other materials you have in the market, since it goes a lot less volume, and it balances a lot, not in the effect, and you can massage it very well. But beware when you inject under the skin. Never inject more than 0 to 3 milliliters with Belotero. This is a patient which I injected 4 milliliters. The first time I injected 1 and 1. Then she came, she wanted more improvement. I injected half and half. All are under the muscle. Then she came for more improvement. I injected like 0.3 under the skin and 0.3 under the skin. Now she got very nice improvement, and I still have some balance from here, which I injected her in nasolabial groove. This patient came for malar improvement, and she could be also improve her under eyes, but she didn't want it. So as you see, there is volume by 1 milliliter in every area. This patient, she has a very bad skin, and she wanted a bit of improvement. Well, I could go for more, but she can't pay more than 6. So as you see, there's improvement in her cheeks. There is improvement like 1 milliliter and 1 milliliter. Improvement in nasolabial groove. She needs more, like 1 milliliter in every one more. And balance. I injected under the eye also too. She could accept more, 1 milliliter in every one. She has a lot of loss. But as you see, she has more positive factors. She seems more younger. For lip, as you see, this is 1 milliliter after injection. There is a lot of a bit of inflammation, but I know that there's like after the procedures like 15% less. It will release a bit, but there is an improvement in the lip. As you see, this was exactly after injection, and this was after 3 weeks to 1 month. So this is like it was like 3 weeks and 4 days. So as you see, if I go from here to here, there is a little loss, about 15%, but still bigger with 1 milliliter. This patient will come next week for another 1 milliliter more to improve a bit up and improve a bit down. As you see, this patient exactly after I injected her, she has 1 milliliter in her upper lip. I know she will lose 15%, and I explained that she needs 1 milliliter more, but she didn't want to pay. For lip with cannula, uh, uh, also all the lips I injected with cannula, I make a small incision in here with the needle, then get in the cannula and inject. This patient, as you see, she has a bit big lip here, and I wanted to give it more volume. I injected 1 millimeter. This is another patient which she want to improve her chin, and in fact, I would love to inject about 4 or 5 milliliters, but she didn't have money only for 3, so I injected her only with 3. She's still retruded, but she's very happy. For lips, this is a lip for 1 milliliter, this is a lip for 1 milliliter. It's very important to understand that lips will not get the same effect, same nice volume, and this is why, because I always explain that for the patient, a very important thing that it's very important to know how much lip eversion you could have. So I will how much lip eversion you have, how much nice lip you will get with 1 milliliter. People who have inverted lip here, I explain them that the lips are not good lips. Maybe I will need more filler, and I will not get to have this wow lips which everyone would dream. So what does Belotero has and as advantage regarding to others, that Belotero, as you see, that provides a smooth transition between treated and non-treated areas. Not also this, the traditional particulated gel may enlarge dermal filler, and this enlargement of dermal filler would be affected and making the skin having lumps. So the good thing that's a cohesive polydensified matrix technology, which allows Belotero to smoothly and homogeneously integrate it to the dermis a day or two after superficial injection. And this is reality. So what the good thing of Belotero, when you inject it, you will never feel it. You will never feel it after 3 weeks, 4 weeks. It's very hard to palpate it. Also, the volume, the one which you put in the malar, in fact, it's you cannot palpate it. I try to always to search if I put fillers in these areas, and it's very hard, extremely hard to palpate. The good thing also that's so natural that when you touch it, you don't see these uh, condensation areas, or in the lip, when you touch the lip, you see it's so natural, so soft. For uronic acid products in the USA, there's a lot, and depends every countries, and we have been talking about the 3 more important products. So general rules: first, listen to patients. Fillers only for volume. Talk about money. Also about first aid kit, you have to have it in your consultation. Beware of complication. I will explain the kit what should have. Sufficient communication to let him understand there are some inconvenience and you may need more fillers, and they have some facial asymmetries or whatever. Remember that this everything I'm telling you just annotated. It's a must in your clinic. Side effects, also talk to them that there are some side effects, but You have to take it into consideration not to happen. Avoid disturbed patients or patients who are unhappy with other products or whatever. Keep up upright. Never sleep the patient to put fillers. You don't want gravity to change effects. You need to see the patient when he's sitting, and you inject always sitting. Use mirrors to explain what the patient want to improve and learn his concerns and see what you can do. For anesthesia, you get in patients who are so sensitive and have fear, try to inject them anesthesia. It's better to take out them fear than moving and they don't want to continue or whatever. Give him them anesthesia. There is no option. Mainly, I don't do anesthesia for these patients, but sometimes there are some who are so fear you have to put. Always reabsorbable material. Also, take care and annotate that the patient doesn't want to pay for another extra syringe, and that's why this could be insufficient material to improve it 100%. Do not exceed and beware of excess with filler of balance and belotero. I mean, you could be so safe because you reduce, where others more they increase whenever after the injection. Also, do not increase visibility and understand patient if something goes wrong. So for pre-injection preparation, you have to see the history, then exam, then make the test if you're putting collagen or whatever. So let him sign the consent, take photos, and explain what you will be doing. So it's very important also to ask for allergies, and as fillers has lidocaine, and there are some patients who have allergy to lidocaine, ask if they have any reaction allergy in the dentist or if they put any dental treatment, and if they say yes, mainly they are lidocaine, but try to be on the safe side. So very important to take pictures because you could get some patients telling you that you have changed something which you didn't do anything in this area. So for collagen, try to do skin test. I will not go for that because we're talking about hyaluronic acid, but you can read this at home and just learn about how to do the skin test and how many weeks prior to treatment. So for photomorphing, there is good. There is a program in Juvederm. I leave you the link up here, juvederm.com.en/juvederm dash visualizer dash, which you could. It's like giving some sophistication for your clinic if you love. So you could put the patient face and try to move this thing. So it's not so accurate, but okay, it's somehow like a gamey way to let the patient see some difference. This is my photomorphing. As you see, there are some improvement for these, but mainly sometimes you cannot give this effect by fillers, and you know that you will have better than this, but not like this. So you have to improve it by moving the arrows in the picture and whatever. So for injection preparation, you could use topical anesthetic like EMLA or Perilox can be used for 1 hour to 20 minutes before injection. So how you prepare, you clean the face very well by scrubbing the face by a treatment. Then you put a lidocaine, and then you put some a plastic bag, a paper which let the face sweat and let the EMLA be quicker absorbed. So and you because of the vasodilatation of the heat. So another effect is if you scrub the face, you're trying to irritate the skin. This hyper vascularity will not be absorbed a lot by EMLA. So also use local anesthesia for patients who have fear or you want to do some blockage. Positioned always sitting on the chair. You should not put fillers when she's sleeping or doing anything because gravity could change staffs. And these fillers are pre-filled, and you can always there is a screw on the top for not over injecting it. Beware for these things, and always use your thumb to try to see if there is vein arteries in this location or whatever, mainly when you inject in sublabial and the subnasal curvature. So for injection preparation, always inject in 15-45 degrees because it's less pain. Needle is inserted with beveled surface facing upwards always. Blanching should be avoided, whereas in like this one, it's when you inject in the epidermis, could do this by Belotero, Hydra, and Soft, and sometimes with Balance in some areas. Also, you cannot do it with all the other brands, and you could do PRP, blanching PRP, which is good for skin, and Hydra, it's also good, and Soft. So the depth is very important. Second is how I want to fill in which type of matrix, and the filling you have to linear it and to in fact move it to adapt. So overproduction is recommended only for lip augmentation because they reduce a bit, and stop injection prior to withdrawal of needle to avoid unnecessary spillage. Treated areas is massaged lightly to smooth the material appropriately and avoid lump formation with Vaseline. Also, maximum 2 milliliters filler per treated session is indicated per area because you could go for injecting in other places or in the arteries or whatever. So try not to inject more than 2 milliliters in any area, specific one area. Uh, Care should be taken to avoid injecting into blood vessels. And again, if needle gets blocked, the pressure on the piton should be increased rather than injecting should be stopped the needle and replaced. Remember that if not, it will pop up in your face. So if someone wants to put another filler injection, beware of that and tell him wait between 2 to 4 weeks. Sometimes they cannot wait, they want now. Never do it in a patient who has a recovery rate less than 1 week and a half. Sometimes you have to know where to inject. Maybe this patient came to improve her tear through, but you see this, okay, why you want to improve your tear through? Let's improve your cheeks, and your tear through will get a better effect. And this is the good thing of doctors, that we learn to improve. We don't learn to just be on the same side. We want to improve, and if there is something better, let's put the better. So where to inject? It's very important to see the face, to make a good facial analysis, to write it in a paper sheet. If someone wants the paper sheet, I can provide it to him by email. Please write me an email from my website. You can get the email, which is www.drnabilfaki.com. So the photographs can act as an effective tool for educating patients on their facial appearance and to explain the rationale of the treatment plan by demonstrating the effect of aging of the features. It's very important to make the pictures and let them see them with him and let him know that he has facing aging skin and problems. So astigmatism is also a must. You have to recite them and try to search for these small astigmatas, which people can see them a lot. After you do fillers, everyone sees his face twice or 10 times a day. So you will always get asked of, okay, I have this is which is different from others, and you know that you didn't do anything, but you cannot solve yourself. Then explain, okay, these are the pictures as you see from the blah blah blah, and this we have in the computer everything which is regarding to you. So famous people has also asymmetries, and Angelina Jolie is one of them, which she has an eye upper than eye, an ear 3 millimeters upper than the other ear. She has asymmetries in her face. She has lost volume in her cheeks. She has a lot of lost volume in the malar area. She has big chin. She is not the perfect woman aesthetically to consider under the extreme perfect measurements, but she's still very nice. Since asymmetries of the face, we could not see them a lot if they are less than 5%, 3% from our visual uh, difference from the other side. So the quantity of milliliters is very important, because how much more quantity, how much more money you have to ask. Normally fillers are double their prices, or triple their prices, depends on which country you're working in. And I think it's fair, because you have to also use syringes and other stuffs and cannulas, which cost also money. And if you need any retouch, you have to take into consideration not to lose money. So which product to inject related to the area? So syringes come like this, only mainly all. They have like a lower look, you can take it out, you could put the syringe in, you lower lock it in, and you take this shield off, which has the name or stamp, and you can start injecting. So consider in male cheek is very important that they have more anteromedial fullness than women. Women has more lateral fullness and more broader based malar prominence and more medial apex and subtly defined. So can I use fillers for which type? Do not use these products if history of multiple severe allergies or severe allergic reactions. Allergic to lidocaine, beware. There are Belotero without lidocaine and there are Belotero with lidocaine, and there are the other one has also with and without. Allergic to gram-positive bacteria proteins, beware that. Mainly the products you have to know from which they are fabricated is from bacillus or from gram-positive bacteria protein. Pregnant or breastfeeding, the safety of these products for the use during pregnancy or while breastfeeding has not been studied. So uh, you should not recommend them in when the patient is breastfeeding or pregnant. Use immunosupportive therapy, increased risk of infection, excessive scarring history or pigment disorder, and may result in increased bruising or bleeding. Also, will do next day strenuous exercise, no exposure to sun. That's the most important thing, and do not massage vigorously without control in the same way as doctor advised. So marking, there are a lot of types of marking, and these pictures are from the internet, taking from other surgeons how they mark, and I will tell you why I mark like this, which is I think is the most complete one. Some people do like this marking, and they want to inject here, 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 and here, here, here. Others do like this from the latter part of the eye to the mouth, and from the ear to the nose. This is a good one, but till now it's not at all complete. Other people do like these for drawing and they want to inject like this. I don't think that is the correct one. Others draw like this a lot and they put a lot of drawing, which I think it's somehow you're not detecting the problems. As you see here, the problem is more in this line than the projection in here. So what I do is this, which you could say that this is the maximum, exactly not like this, but in a philosophy, I mean, and I could see what is the malar maximum height. Some doctors do this and can treat it like this by this marking for the under eye. Yes, you can do this, but for a specific thing, I started doing this, but I shifted to other styles, which I will explain. Others do the Audi type of three circles and inject one less here, more here, and less here. I think that also does not give a lot of information. This marking is very important to know where is the maximum medial part of the cheek and the maximum cone part of the cheek. So it's where the center of the cheek will be, and you draw a line from the ear till the nose, and from half mid of the ear, and from the uh, lateral part of the pupil, and when they intersect, then you know that this is the maximum part of the cheek. From here, that guy draws like these circles to improve. Yes, it's good to see. Others draw only the line from the lateral pupil to the mouth. This is incorrectly. It's, as you see, it's from the from the pupil which intersects with the this line. Okay, and this line is too low. You have to make it more up from the tragus to the nose, where you could know the maximum height of the cheek. So what I do is these lines I draw from the lower part of the ear to the lower part of the nose, from the tragus till the half mid of the ear, and from the upper till the this part of the eye, which I will not draw here and here, and then I draw from the lateral part of the eye till the lateral part of the mouth. So by this, I could see where are the defects are in the middle and a bit here. There is a defect in here, a defect in here, defect in here. So by this, I make squares, and these squares let me see a lot of the defect. Also, this patient did Botox and whatever, but as you see that you can learn understand, and from here you could see that there is good here. If in this square it's good, there is good, but there is a bit of here loss and a bit here more loss and a bit more here. Make small squares, let you understand. You can make a bit more square, which is from the lateral eyelid, and you draw a line from here to the nose and when intersect. This is the maximum part of the eye. Again, I draw a line from the lateral part of the pupil. It's like this here, and I go a line from tragus till the nose. And as you see, this is the part of the chin of the cheek which should be improved and get a lot volume, the maximum volume. As you see, then you could draw things which you could think that there is a lot of loss. As you see, the OV curve is an inverted Y, and the injection technique is very important, that you can inject in any area in the skin. You can inject the upper one under the skin by using different types, as a linear threading technique, a serial puncture technique, or cross hatching technique as this, and or fan technique like that. I usually use more cross hatching and a fan technique, and sometimes I use linear threading lines in some areas, and for specific cases, since I shifted to cannulas, I use injection puncture by syringe. The others I can do them by cannula with a lot of less pain. So for combination technique, you could use Botox, and as you see that you can combine it with fillers, and they are good friends. So this combination are very important, and there are some studies saying that the follow-up of why using Botox over the filler. So they have made a study that using Botox A slowed degradation for the injecting filler. So at 3 months, chemo with Botox A decreased the degradation rate of hyaluronic acid filler by 42%, and the remaining volume of hyaluronic acid filler was 50% greater than the side where Botox was used. So some people, till now it's in studies, and there is some people started using after they inject the filler, they inject a bit of Botox, and by this they improve the area. So avoiding pain, you could use cold. Normally, I do put anesthesia for the first pin of the cannula, because I want to go with cannula, because I do it with cannula, and with cannula is a lot less pain. You could use also these machines, which is cold machines. You could use the vibrator. I have this vibrator at my clinic, but a lot of patients they become somehow nervous because it's vibrating, and they become nervous and they don't want the vibrator. And I've seen a lot of patients tell me, "Can you please do it without the vibrator, because it makes me nervous?" So uh, also you could use topical anesthesia or local infiltrative anesthesia or nerve block. So for EMLA, you have to use it for 30 minutes before. Try to put some tape or try to put some plastic bag to let the EMLA absorbs a lot. So also you could put EMLA like this, but you have to wait. You cannot put EMLA in 2 minutes and start using it. The anesthesia, it's better if there is a patient who has a lot of fears. Normally I get a little few people who have a lot of fear. So in my base data, I mainly use it without anesthesia and without xylocaine cream. So for anesthesia, let's say for the hair or for the any part in the frontalis, or there's any loss of volume in the upper part, you can use the supraorbital and the supratrochlear nerve, as we have learned them in another presentation. But you could see that this supraorbital nerve, you can it's the half pupil or a bit somehow medially. The supratrochlear is more medially, and you can block this, and you can have anesthesia till uh, half part of the head. So the infraorbital one, also you can fix it, and you can anesthetize it, and you could just go into the mouth or from the upper part of the skin. Remember that the difference between them, that some people prefer from the mouth because it's like the dental, and they say that it hurts less. Others tell you the contrary, that they prefer from the mouth, from the outside, from the skin as the first picture because it hurts less. So you have to give two options, two offers. For the chin, also you could inject it from under the mouth, for the mentalis nerve or from outside. Remember that this nerve goes out between the two premolars. Many in all drawings are between the first molar and the canine, or from the maybe also more anteriorly. Remember that this is not the final result, and the normally the lip and this area of the of injecting the nerve is between the two premolars, not between the molar and the canine. You could use other selective anesthesias, which is injecting special areas by fanning or whatever. Remember that put less not to camouflage area to be treated. That's why I put anesthesia for cannula and go to treat with cannula, because I will not change the result. Also, never let the patient feel during the aesthetic procedure, because if he has pain, he will not do again the treatment with you. Any negative experience may mean the patient will refuse or more or others. So again, when the depth of injection, it's very important to know where it is, and you have been learning in the session where to inject, if under the bone or under the muscle, and we will explain it more lately. But remember that types of needles we have 25G or 27G, which are flexible, or 25, 27, and 31 uh, uh, needles. Also, I have to tell you something that with Velotero you could use the 27 gauge to inject all the things. I prefer for the lip 25 gauge, and for the other part of the face 27. For the lip, I need somehow constant power in the needle, the mic in the cannula. So if you use a thinner one, it will somehow flex, and sometimes you don't need this flex in the lip, whereas in other areas these cannulas which are flexible are very important to avoid vessels or everything. And also buy them for the non-lip uh, fillers, which are cannulas which are not bullet. Beware, bullet only use it for the lip, because it will have a super glide effect and will glide better than the others. So for the area vessels, I use in fact cannulas of a lot of brands. One of them that is very good, the one who comes with Belotero volume, you could use it for all areas. And for the lip, I get from TSK one cannulas which are uh, for gliding, which is bullet cannulas, and you could ask them, and I get that 25 gauge. When you get the cannula, it always get a needle to open it first, then to use the cannula. So area of vessels is very important, that when you inject at the face there is a lot of vessels, a lot of hematoma. It could happen, and the patient should know that before you do any procedure. So for the forehead and area, so you could use Botox or dermal filler. Remember that multi-level injections, retrograde tunnel injection, or simple injection are good for this area. I try to camouflage all these wrinkles, which is your effect, and try Botox 2 weeks before, then filler in this area to enhance it. Tell them that sometimes you need fillers and Botox to enhance it to get a 100% or 90%, than using only Botox and the patient comes so sad that she lost her money and she didn't get improvement. And then you have to do treatments more on her. Let her know that from the first. Also for the eyebrow, you could put some filler to improve the eye position and to erase it a bit. Some people try to come to put fillers. Also, it's very good for improving the eyebrow. Also, remember that if the patient doesn't want a lot of filling, and you fill in that area, you have to take it out all. So go stair step and slowly to improve it, the elevation. So for tear through, mark always and inject submuscular, which I think it's the best thing.
a simple injection of 0.2, and you start camouflaging it and you putting it. So mainly I use 1 milliliter of Velotero, and for this patient I will not be using 1 milliliter, but maybe half syringe or less than half syringe. So I should check that and see how much improvement she can have, and from here I could know if she needs more or less. For cheeks and cheekbones, also mark the frames always. Inject subcutaneously or subperiosteum over the bone for the cheeks and the cheekbones, and does not require anesthesia because it's very tolerable. For this area, I could go with cannula, never go with syringe because they will have bruise. I put some anesthesia here and go with cannula to treat this area. And for the eyebrow, I go also with cannula, or in some cases you could use a syringe. And you start injecting here and elevating from here to here subcutaneously. For these areas, I go for epidermal or surface, superficial dermis, and I treat it by injections. So for nose reshaping, it's very important to understand that it's the most complicated area because you could have more complication, and evaluate the line of an A, which is very important for orthodontic, and always check that she doesn't have a retruded chin before you do any procedure on, and to annotate that because some patients uh, they need fillers, and they put fillers and they always say, oh, I'm still retruded. Just let them know that retruded chin also could go with noses, and sometimes you have to enhance the nose and enhance the chin to get a better result. So for nose reshaping, evaluate always the nose, and normally it's for excessive hump, and you want to reduce it before the excessive hump, the depression you have. Also, nose is so sensitive. Anesthesia to the ophthalmic and maxillary artery are good ones. Vessels pass subcutaneous over the muscle, so you have to inject. If you want to inject, is under the muscle, always under the muscle, as you see in the image, how vessels are over the muscle. These are more nose, and remember that there is limits for nose reshaping. For nasolabial folds, stretch skin helps you visualize folded and ensure that the material is injected inside. Also, as you see, as an advantage of using cannulas, that you could not go in the artery, and by this you could have a lot less complication. See how much the percentage of artery could go in the position. If it's over, it's below the crease, or in the crease, or cutting like this. So all these are things to take into consideration, that always it's below, not always, around 50% that's below the crease. So for the naviolateral groove, I go subcutaneously, and if I want to inject this area, in the area of the triangle here, I go with a needle till the bone, and when I reach the bone, I release maybe half the amount of intense in this area for this patient, and mainly she needs maybe one only for this area. Then if you want to improve this area marionette lines, you could put anesthesia here. You could go with a cannula and try to fill subcutaneously, which will elevate better. And for this area, again, you go in here with a cannula and you put subcutaneous, or just go perpendicular to it with another cannula. For upper and lower lip, remember that it's very important that you do it with cannula, because with syringe it's so painful. There are some doctors who doesn't put anesthesia, and patient should suffer a bit. Some other doctors put anesthesia, but if you put anesthesia, then the patient, when he goes out, he somehow has a facial paralysis, momentum facial paralysis, which will solve alone. But remember that that's why I don't want to talk with them and leave my mind easy and tell them, okay, I don't have any relationship with the car, and try to uh, to get another car or whatever. Uh, for that reason, whenever you wanna inject in in this area. So what I tell them also, that for the lip you have to take into consideration the pain. So by cannula there is no pain, and you don't have any facial asymmetry. You can go home without these, with your car without these facial asymmetry problems, and no pain at all with cannula. Whereas with needles, if you ask them, and they will tell you, "Oh yeah, I know a lot of patients who put with needles and it's so painful." So you have to give him then anesthesia. So other possibilities to do it with cannula. So with cannula, the pain is so tolerable and it will have less inflammation. It's very important to understand the lip anatomy and to have guide in how the lip is contouring and how what it's made of, what's the vermilion medial zone, the lateral zone, the subvermilion zone, all this information. So for upper and lower lip, you could also inject in these lines some soft or balance to improve it, or in the lip to get a bigger lip. I use by cannula. I inject some anesthesia in the lateral part and reverse it more. So for the marionette lines, also she has marionette lines. You could inject buttocks in the Dao muscles. You could learn this technique from my presentation of buttocks, but uh, also you could use some fillers and still improve it a bit. But remember that sometimes you have to put more material and to give it a more balanced with her face, because she has a lot of crease. In this area, I try to make triangle feathering or I'm sorry, or retrograde injection or single site injection. Inject always medially to the fold. So for mandibular and chin reshaping, you have to inject over the bone, and you have to inject a lot of materials, triangle and feathering retrograde technique with multiple layer injections. Deep and superficial nasolabial fold might require a multiple level approach. For temporal area, single site injection, one layer injection, which is I prefer to inject it over the bone exactly, and you have to use a lot first, sometimes 2 to 3 milliliters in every area to improve its depression if it has a big depression. So every patient is needs a bit more. Try always to tell the patient that you have to inject, okay, maybe two, but we start with one and we will see, and then we inject the other one, and if we see we need more improvement, we can inject the third or wait for 2 weeks and decide if we want to inject more. For post-procedure instructions, avoid exposure to extreme cold or heat, which could alter the viscosity. Avoid massaging treated areas for 6 hours. Avoid strenuous physical activity for 6 hours. Sleep with head elevated for one night. Pain medication can be taken if needed. And resume skincare products such as retinoid alpha reset the day after the procedure. Post-procedure instructions. So makeup, try not to use it for 12 hours. No other treatments for 7 days. Laser for 2 weeks. Massage for 6 months. Let them have a phone contact number to call you if there is any problem. I try to give my patients my phone number, because I think I'm the doctor which they came for them, and I think the one who will solve these or calm them or try to let them know that there is a complication is me, which I will take the decision, and it's in fact your reputation always. So that's why I give them my phone number, which is for emergency, and should patient should just get re-evaluated every 2 3 weeks. I always try to let them come back after 2 weeks, but mainly there are a lot of patients who doesn't come. Also, there is another sequence of 8 points facelift injection, which it's described by a famous doctor, which explains about the procedure step by step. You can search it online. I never did it for this procedure. I don't. I think that's few material to get a facelift effect. It will get some volume effect, but I think you need a bit more to enhance these areas. If I see this patient, I may think that she needs more. So for flexible microcannulas, I use the magic needle, which are the best, and they are so flexible. The good thing of this needle that it reduces pain of injection, reduces of necrosis, and reduces recovery time, and permits a better application. As an advantage for this is that is the flexibility, and you could have good movement in it and slides very nice into the skin without damage. As you see, it's not a bullet one, whereas in the disadvantage that there are some for the needles that they are which are blunt tip needles. You could have more bleeding and limited choice of handling. With cannulas you could move very well to all areas and try to work very well. So you can fan shape, you can inject in spoke while wheel pattern, you could do whatever. So with traditional needles, as you see, a disadvantage is that you can have more breathing because they go in the vessel and they cut. Where for cannulas, when you inject it, they transpass the vessel and they do not affect it. So how much cannula you wanna use for the face? I will give you one thing. I use 25 gauge for the lip, and for the others I use 27 gauge. Uh, you can use 25 also for the face, but it's somehow more painful, a little more, which is, I mean, it is a lot less painful than needles. But let's say that it's a bit and this more bit. So I use 27 for the face and 25 for the lip. And with Beloteri, you could use all these fillers they have in the market. With the cannula, you would need it 27 or 25. So I use for the lip also. I said that it's a bullet cannula from TSK, which is the Glide Super Glide, and for the face I use the Pelotero volume cannulas, which every box has two. So for using cannula, you have to use first the starter needle, which it comes in the box. You take the starter needle, you make a small hole in the face. Then from here you insert the micro cannula, and then you use the micro cannula only for every patient once. It's not it's one use. So for fillers, we try to inject with micro cannula, and you will see the technique of every part. First, for the molar area, we need to get a needle, make a small hole with the needle, but previously we put some anesthesia. With some anesthesia in this area, we try to go with the cannula to all the part of the eye or to work on the molar. So after I put some anesthesia, I go get the cannula, I inject the cannula. So remember that you should always go submuscular. And how you could know that you are going submuscular? It's so simple. You get the cannula in, you inject it under the muscle, and when you inject this, you go till the bone. And so when you are over the bone, you slide in into the eye. So like this, you can assure that you are submuscular. Also, to assure that you are submuscular, you try to elevate the cannula, and if you touch it here, like you can feel it, so you're not submuscular, you're subcutaneous. When you are submuscular, it's impossible to feel it, and by this you all only see that there is some muscles in it, but you cannot touch any cannula. So whenever you inject in the malar area to treat the tear through, remember that you have to go submuscular in all this area, where from the external part the muscle is so thin and the skin is also thin, but you can feel more the cannula wherever you go submuscular, but always you are over the bone, exactly over the bone, and submuscular. Mainly
if you use Belotero, which I use, you need like 1 cc or half cc to treat the tear through. So what I recommend always, try to work this under the muscle. Some patients will come back and let you know that there are still some a bit of depression. Tell them that okay, now you could go for subcutaneous filler. I always recommend that we will improve or camouflage this area, but sometimes you cannot treat at all if there's a lot of fat. So by this we're camouflaging. Uh, So when you finish your tear through, doing the tear through and the tear valley, you could go for the malar. You can go for maximum augmentation area. As I've said earlier, you can treat in this from here, from the middle, you can treat all the eye. I will always go submuscular, and mainly in 80% I go submuscular. In some patients, I could go a bit subcutaneous in here, putting 0.2 to 0.3 milliliter. Always treat tear valley, and this is tear through. So for the under eye is this. For the brow, you could put some, go with the cannula from here and inject like 0.3 to 0.4 milliliter of Belotero balance to give volume to this area. For the temporal hollow, you have to use a volume, a big volume. So for big volumes, you use, and this, for this patient I could use maybe 2 cc's, while in fact some doctors dilute this to inject it and smooth it all over. I've never diluted it. I inject it directly in. I get the cannula and I go till the bone. Sometimes here posterior there is some muscles, so you could feel that you are so deep. And try always to aspirate. This area is a very dangerous area, since we could have uh, uh, subcutaneously the arteries and the vein of the tempora. So to go on the safe side, try to inject with cannula. If you inject with cannula, it's so safe. You could go till to feel the bone, that you're over the bone, and they try to make a fanning. Sometimes you feel that you're better doing it with some needles, so you could go with needle. Try to inject when you feel the bone, you elevate 1 millimeter and try to inject the filler in various, then massage in various points. As you see, she has some hollow, and you could go with some needle and improve it, as I've told you. Uh, for the nasolabial folds, you could go also with a cannula. I try always to do it with cannula. You put some in here with a needle, you open a bit, you get in the cannula, and you go with the cannula to treat the medial part, always trying the medial part. So what I do is, if I want to put 1 milliliter in all this, 1 milliliter of intense from Belotero, well, I leave like 0.3 to 0.4 in this area, and try to decant like 0 to 3 to 0.2 and 0.1, and try to put more up here to improve this. Which patients, some patients, when you feel that you want to improve these lines which decrease, I always can go with a needle and try to inject subcutaneously only in this area to try to solve. I not always go from here to here. I try always also to put it like this, to cross it, so I could have more support and release this tension from here. Always try to massage. You put your finger inside and massage it very well, very well. So, but in this area, you have to take into consideration that the artery comes from here medially, as we have explained earlier, and the veins. So just take into consideration whenever you go with a needle. So if you go like 1 millimeter, 2 millimeter, it's nothing. You're subcutaneously. But whenever you go with a cannula or with a needle, if you want to go deeply, beware. You can inject. That's why I only inject with cannulas. So to be in the safe side, always when I get with the cannula in, I try to aspirate. Remember that if you're using a small cannula, and the artery is very small, sometimes it collapses. So that's why always you get in the cannula, never bullet cannulas, always not non-bullet cannulas. You try to aspirate. For this area, I use the same cannula that the Belotero volume gives in the box. So you massage, and here we have. So for this case, as you see, to improve more, she has been like this, but to improve it more, you see there are some lines which we need balance or soft to improve it. We can inject maybe 1 cc to improve all these lines. Sometimes with we have improved the volume loss, but we did not improve these lines, which are have been contracted by a lot of years. For the lip, I put some anesthesia. I use, as you see, this needle. This needle is called Invisible Needle from TSK company, which it's a 34 gauge. In fact, it's a 33 gauge, but it's a 33 plus, which is thinner than 33. So we call it 34, but there is no 34. So we inject anesthesia first in this area. Then when I inject the anesthesia, I try to make with this needle a small hole, which comes with the cannula. I use for the lip, the only area where I use 25 is the lip. The other areas I use 27. So I get in the lip with this 25, which is somehow more solid. I go in directly. It has less pain. This patient doesn't have anesthesia in her lips, only in this area where I made the small needle pinch to get in the cannula. And I try, when I inject in the lip, I never inject in the center. I try to inject from the first 1/3 of the cupid bone. Then I never inject in here in the corner. I inject till here. So all the filler is released in here, never here and never here. In some few cases, you could inject in the anterior part in patients who have a lot less elevation or need some volume in the center. But mainly, you always think the same thing when you only inject from here to here. The fourth 5 days, you see that, oh, why should not put in the center? I see it somehow uh, hollow a bit compared to this. This is inflammation, then it will adapt and it will get a very nice lips. So then you get it and you massage it from the center to the last part. Try to massage a lot. Sometimes if when I improve this area, you could improve also by cannula. You get in and you try to cross hatch it. For this patient, that's from my colleague, that as you see that this is his marking. I don't do this mark, but I want to explain it in to act in the face of everything. You can react in the face, you can walk in the face. As you see that these are some points where you could use to improve the drawing of the malar area. When I enhance, this is the sad face, you could enhance it. The more the marionette lines, more the nasolabial groove. So what we do, for the under eyes, you could just go with a needle with a cannula and try to inject submuscularly in all this. I usually inject between 0.5 to 1 cc's in one eye. As you see, the difference between fillers also is very important to know them. You could see that the balance could be somehow more flow, the volume it could be more thick. So you go, if you see, when you go in and you try to elevate, if you see, you can touch the camera, so you're subcutaneously. If I go more deep and try to elevate, I cannot feel the cannula in here. So here, if I try to elevate it, I cannot feel the cannula. So you try to massage. Then for the malar, you go in here and you try to put like 0.5 here, more here, and then more here. So you try to inject. Or sometimes if you want to improve also the malar lateral contouring, you could go with the filler from the lateral area like this, and you just go in and leave from here to here and try massaging to give it like to draw the malar. The good thing is of cannula that you can draw in the face of the patient. In all these, you're going subcutaneously, okay? So don't fear about how much you could massage or where they will be deposited. Massaging is very important to expand the gel in everywhere. So whenever you inject in here, you're not injecting only here. You're injecting, and everything will move beside it too, because the hyaluronic acid, when you massage it, you expand it everywhere. You try to massage is very important. So for the nasolabial groove, you could put some anesthesia in here, go with a cannula, you go subcutaneously, exactly like 2-3 millimeters. When you reach in here, try to aspirate well. Then when you aspirate, you try to inject like 0.4 to 0.3 milliliter of hyaluronic acid. Then the rest you leave it in. I usually use for molar between 1 cc of volume and 1.5 cc. It's not so much. What I'm telling you, I'm doing natural results, which you always say, okay, maybe I should put some more, but it's better to make natural result than overdone. For the eye, I could use between 0.5 to 1, depending how much hollow it has. For this case, I could be using 0.5. For the molar, for that case, maybe she needs 1 only in every one. For this area, she may need only 1. With this area admits a lot, so don't be fear if you put only 1. Try always not to put this area without putting the malar, or don't put in the tear through without putting the malar. The malar is a must always to improve if you have someone any problem in the nasolabial groove or in the under eye groove. So you go with the cannula, you leave a lot in here and you release. So for this area too, you go in here, you try to release. As you see for the lip, as I've been explained earlier, you could go this by this inside and you leave it. Never act in the middle, never put in the lateral part. So as you see, you could feel it and you can release it a bit. Also, if you want to contour, you can go from in with the cannula and try to go over the red lip a bit and try to leave it a bit. It's better to do it with cannula because it stays all in the same level. That's why I prefer cannulas in the lip, because you're always injecting in the same level. Whereas for the inferior, you could always do the same. You go in the cannula in here and you try to leave the filler inside. Always never put a small bit in the center, small, like 0.1, and then the other volume exchange it. The center could add in the inferior lip could add bit in the center. So as you see with the cannula, you go in and you release it, never in the corners of the lip, like 5 milliliters beside the corner, never inject. Then you massage. For this area, you go also with the cannula and try to cross hatch it to improve the support of the lip. Always subcutaneously. Remember that the artery comes from here, you have to aspirate, but if you go subcutaneously, not so deep, it's safe. As you see, you could cross hatch it like this, then you could go from up here and cross it, so it will give volume to it in this area, which sometimes some people have depressions, and this lip will elevate. Always you could also put a bit in here to try to elevate the support the lip. For the chin, what you do is you mark what you have to adjust, and you can go with the needle directly in the chin, in the center points. But sometimes if you want to improve this depression here, I have to go with the cannula. I try to make in a small pinch in here and go with the cannula and leave here, or sometimes make a small hole in here with the needle and get with the cannula from here to here, always subcutaneously. When I say subcutaneously, it means like some millimeters below the skin, trying always to be like in the subcutaneous part. So for the cheeks, you could always do my drawings, which is better to see the problems. But for lateral part of the chin, you could also go subcutaneously and try to put. You mainly need about 1 to 2 minimum cc's. I usually recommend for every patient in every area minimum 2 cc's to 3 cc's. Depends, but if you wanna give volume in this area, you need a lot of cc's. So for the chin, you could always do the same like I've explained earlier. You wanna treat also this area, you could improve it by a cannula, always subcutaneously. As you see, first you could go subcutaneously, and by this one, it's only to let you see that when you go subcutaneously, you can see the cannula, but if you go more deeper, you cannot feel. This is I'm elevating here. As you see, if you elevate here, you could not feel this range since you are under the muscle, but in this area you are subcutaneously. For the nose, you could also come from here to leave to correct the problems in here in the medial part of the dorsum. If you want to correct problems in the upper part, you have to go with a needle. You can reach the bone. Always reach the bone and leave the filler. We have been treating also this area, as you have seen that we can go with a cannula and try to improve this transition from the chin to the angle in people who are having glass tooth. This is also for the lip. So before I go for here, I want to explain a bit how much cc's you could use in every area, and I want to go for a face. Let me go. So let's say that this is our patient and we want to inject. So what I use is, as a summary, for the temples you should minimum use 2 cc's and up to give some notice, and the patient could be happy. 2 cc's in every one of the temples. For the brow, I could use 0.3 to 0.5 cc's of. For the temple, I use Belotero volume. For the eyebrow, I use between 0.3 to 0.5 Belotero balance. So for not avoid, if you want to use another brand, okay, I can explain it in another way. I would say big volumes, which is Belotero volume, or any others of the fillers of Juvederm volume. I could say, or Restylane, Perlane, or Subq. For medium, I would say medium filler, which is intense, which it could represent Belotero intense, or Juvederm Perlane, or Restylane Perlane, sorry, Juvederm volume, or sorry, it's not volume, I forgot, it's number 4, or Juvederm, I think, let me get 1 second for that, since I'm not using any more Juvederm. I forgot which was the second one, but I will let you just go out of this knowing exactly what it is. So for the medium of Juvederm, it will be in here a bit. So it would be, if you're using this, it would be Ultra 4, but for the new, it would be Vola Lift, and if you want to use the other one, it will be Juvederm XC. Okay, so these are the Juvederm brands. I'm using only as you see, Belotero, and I will continue explaining for treating all these areas. So if you want to treat these temples, you need big volumes, minimum 2 cc's. If you want to treat the eyebrow, you need soft, I could say, like balance. For Belotero. For Juvederm, it could be the XC or the X Plus. XC Plus. For Restylane, it could be Restylane L. Whereas for under the eye, you could use also the soft. In Belotero, it would be Belotero Balance. I would use like 0.5 in every eye to 1 cc, depends how much hollowness. And I will be treating it from here, going under the muscle and treating under the muscle. Here I could try subcutaneously. Okay, here I'm trying over the bone. So again, over the bone subcutaneously, and here under the muscle over the bone, I try to leave in all this area. Remember that this area is somehow thicker, but this area, the muscle is so near the skin, so you can feel the cannula. Here you should not feel the cannula. So for the malar, I try to give a bit in the here in the paramalar, then in the malar area, which is the maximum, which I could draw a line from here and a line from the center to the nose. So I know that this is the maximum projection of the molar. I inject the maximum here. Like, let's say that when I inject 1 cc's, I could inject here 0.5, 0.2, 0.3. So by this, I'm improving. Never over inject here, always over inject in this area and leave it a bit more here. Depends the patient also, the malar problem. Some patient has more here and less here. You have to improve this area, but mainly a lot of patients has a malar deficiency in all the 3 parts. So for here, I use minimum 1 cc to 1.5 cc. I think using Belotero volume 1.5 cc, it's good to correct a medium patient depression. So for the lip, I try to put with a cannula in here. I try to go with balance, which is the soft one. The good thing of balance, that is so smooth, you cannot feel that you have put some fillers, because so smoothly. Remember something, that if you want to overcorrect, do not use volume or others, because the lip will have a feeling of solid lip, and no one loves this. So use 2 cc's of balance. It's better than using 1 cc's of Belotero Intense. Okay, so that's my recommendation. So for this area, if you want to treat the this depression in here, I could go with a cannula from here. I could put one a half cc in here and half cc in here. I will use Intense, Velotero Intense, which is the medium for the fillers. If I want to treat the nasolabial groove, I would use Intense also, which is the medium of all the fillers. I could go with a cannula from here and go in here and leave the maximum here and release here less and less. So I'm going subcutaneously also. In the lip, I'm going intramuscular. So also, if you want to treat the chin area, I could go over the bone. I leave here a bit in the center, then I leave more in the lateral, a bit more in the lateral part. Then if she has a depression in here, I could go with a cannula from here and try to leave in the subcutaneous area. In here, I could go with to reach the bone in the center. So for treating the mandibular angles, I could go for the going with a cannula from here back and try to leave in a bit from far till here. Just put more in the posterior part, since we all have more in the posterior. For people who have affection in the buccal fat pad and they need some volume because they are so thin, you could also go with the cannula subcutaneously and try to inject in about 0.5 to 1 cc. Remember that in this part under the cheeks, 1 cc of Intense, if you want to use, it will always be on the safe side. Remember that in the lips I use only Balance, Belotero Balance. In all the part of the face I use Intense. So also you could do a lot of combination treatments, as we have seen, but we will be shifting now to see how are the complications and what things we could have and how we can solve them. So for the complication, we could have pain, bruising, erythema, asymmetries and bumpness, anaphylaxis, edema, any eruptions, reaction, infection, reactivation of herpes simple, and or for late inflammatory nodules, Tyndall effect, allergic reaction, vascular occlusion, granulomas, implant migration, telangiectasias, lipoatrophy, hypertrophic scarring, or sterile abscess. So what we will learn now is how to treat all these problems. So for redness, it's from immediately to 1 week post injection. So the treatment always try to with arnica and histamine, and some you can add some antibiotics and steroids if there is a lot of redness. And the treatment, if you want to take out all these and it's constant, you could put hyaluronidase. It should resolve between 1 to 4 weeks if it occurs. This redness mainly occurs when you inject it, and in the first 24 hours, then it mainly should go. But if we're talking if there is a complication of redness. For itching, well, in fact, it can itch to 2 weeks. I always ask the patient when they come after 2 weeks, I try press over it. Does it hurt you? If he says yes, is it because there is some collection of hematoma? So in fact, it's from immediately to 1 week post injection or to 2 weeks. Depends if there's still the hematoma in here. You can treat with anti-inflammatory if the patient just tell you that it hurts him, but mainly I try not to give anything that should resolve easily between 3 days to 2 months in some if we have complication. Firmness. So firmness is very important in the lip, and it's related to materials. The first maybe day to 2 weeks could be from the injection and inflammation, but if you inject Belotero Balance, there will be no firmness. With other brands, you could feel all firmness because it's of the material which is more solid. And in this case, in this patient, I try always to tell them, okay, massage before giving any treatments. Always any complication you could feel it, you have to give antibiotics and try to take out the filler. But if you see in these treatments, I'm trying to give you, this is the recommendation of what they do, but I'm telling you with my experience what you should do. So for pain, It's immediately after, normally to 8 days to 2 weeks. As much as I told you, it's more about hematoma, so it should resolve alone. No need to do anything like, except like, okay, take calm, try to take some pills, anti-inflammatory, and could be some people could have nodules and or any problems with these. You have to use your days. Swelling and bruising is normal in areas which it's so sensible, like under the eye, which it could be for 2 weeks, or the lip to define. Finally, remember to tell the patient that this inflammation will make the lip be asymmetrically for some days, maybe a week or 2 weeks. So let him doesn't bother him that he sees that this part you is bigger than this. It's more related to trauma or bleeding in the lip of some veins which you could go in. So let him know and understand that. For swelling or bleeding, as you could see, some patient could come by this. Tell him that we have to wait for maybe 1 week, 2 weeks to see. But if you see that it's a complication because it's a doctor who put it under the skin and he put a lot of material, you have to use urinidase. As you see that when you inject the urinidase, it goes quickly. So Tyndall effect, for people who doesn't know what's Tyndall effect, I've never seen any case, so I don't have to share this picture from internet. So the Tyndall effect, it could be like a bluish area, and mainly under the skin, which are so thin. Remember that this Tyndall effect, I've never had it with Belotero, and sometimes if you go under the muscle, you will never ever have it. If you go under the skin, it may be if you use intense or volume, but the company says there is no Tyndall effect with Belotero. So I've never had any that case. So I don't know to tell you. Nor I had with Juvederm, nor with Restylane. I always be safe and go to inject under the muscle. So if there is, you have to inject urinidase and to take it out. For nodules, as you see under the eyes, it could be superficial injections, and some brands which are cheap brands could make nodules. As I've let you know that the Belotero doesn't leave lumps, and that's why I try to use it. I'm not trying with this presentation to sell any product, just telling you what I think. It's my recommendation or what I have confidence in this product. I've been using the three brands are very good, but everyone has an advantage, and I've seen that this is the advantage of of Velotero, that's in the lip. It's so smooth, it doesn't feel that you put something. Also, if you put in any part of the face, you cannot feel it. Also, it doesn't make slumps. So that's why I'm so happy with this product. And also, it's one of the best products, and it have won the aesthetic injector of the year. So they can resolve in 2 weeks sometimes with some fillers, telling the patient to massage it. But sometimes these nodules, because there is it collects a lot the in this area hyaluronic, and it makes like a nodule over it. So try to give antibiotics if there is any sign of infection, or steroids. But you usually doesn't you don't want to go for that, and you try to take it out with urinidase. So infection also is very important to make a sterile area when you go with cannula and with any needle, because some patients has bad skin, or uh, he came to your office and the dog before he came to the office, he licked his face with his tongue. So this dog has a lot of bacteria in his mouth, and you go and you don't do a very nice clean area, then because you think that the skin normally doesn't have a lot of bacteria, when you want to treat it, you could put a bit of alcohol. But sometimes you go directly with a small bit, and you go with the cannula touch the skin, which there is some bacteria of the dog. And I'm trying to give you an idea, but try to clean very well. It should resolve with antibiotics and with anti-inflammatory. For abscess, also you could have, so for infection. So that's why in these cases you have to start on antibiotic and steroids injection, intramuscular, and yearly days to take it out. It should resolve between 4 to 6 weeks. For allergic reaction using silicone, this is a patient from online. I don't know what she has, but it can represent a patient with silicone. So as you see in these patients, this allergic reaction, you have to treat it with local steroids, but you cannot go a lot with local steroids. So you have to go for surgery and take out what you can. Normally, if there is silicone, you cannot take it out all. So also inflammation could happen, which could be normal, but not like this. This is most an infection inflammation, and this inflammation they have to wait because it takes sometimes between 2 weeks to resolve finally. So for deeper wrinkles and scar, sometimes you have to inject with a needle, and you can make a scar because this patient has hypertrophic problems. So beware in patients who have hypertrophic. Try to tell them that when you go with a needle, when you inject with me hypertrophic. Okay, so also deeper wrinkles and scar has been reported infrequently but more commonly after treatment in glabellar region, in areas when you put some fillers and they contract in this area, and they make to let to see that there are more wrinkles. So for displacement, also it could happen more in fillers who are non-hyaluronic acid. So they could displace like silicone or whatever. But in hyaluronic acid, it's very hard for displacement since it accommodates where you inject very well. So for vascular occlusion, it's very important to know that we have three arteries: main artery, the labial artery, the angular artery, and the supratrochlear arteries, which are related to the problems, and they are part of the fascial and artery and vein. As you see, our face is a lot of arteries everywhere. So when you go with a needle, you could go everywhere in this end. So that's why it's better to inject with cannula. You're going always with a secure, although a needle could not go in here, but could go in here. So what happens with vascular occlusion? Okay, as you could see that the effect of a small filler bolus, what could may do for. So when you inject typically in the artery, it will go like directly from here with the facial artery and to the distal branches, or from you inject in the supraorbital area, it could go from the angular arteries. They will go directly into the ophthalmic artery and will block the eye. So when you have a big bolus, it will go directly in here because the arteries will lead it to here. But when you go with a small effect, it could go for a micro volume or fill. It does not completely obstruct all the blood, so with less problems. So that's why you have to inject small bolus slowly. So, and when you inject in the beside the supraorbital, and you try to affect the supraorbital, you could have a skin necrosis of this area. So always in the graveras, inject above or below the muscle. So remember that you inject below the muscle over the bone, or very subcutaneously. Never go in half mid areas. So for the also for the angular, when you inject in this area, you could make a vascular occlusion from the ala, and you need to make reconstruction to improve this area. See that this patient is from this article. Imagine that it's your patient and she comes for fillers, and she finally goes home with a surgery of the ala, and thanks God there is a good reconstructive one who made it very well and somehow natural, but still a surgery and a complication. Also, some it will this patient start always with these things, as you see with some hematomas aspect of vascular occlusion, and as you see it comes again to dark, which is necrosis in few hours. So also the labial arteries could be affected. So nasolabial folds are affected by the occlusion of the labial arteries, and it's very important in here. So as you see in this is a study from topographic anatomy of the labial artery for dermal for injections. As you see, we have 56 persons. They are type 1, which the SLA artery and the ulnar branch both arise directly and independently from the fascial artery. So it's very important that this is the fascial artery and the superior labial artery, which is the SLA, and mainly about 56%, the SLA and the RLR branch arise directly and intermittently from the fascial artery. But we have others which the artery is absent, or the SLA terminal branch is a terminal branch of the fascial artery, and other that the SLA branches off from the fascial artery and gives the other branch. So this is a very nice study, and they have located that the SLA is located 12.1 to plus 1.3 millimeter lateral. So it's very important this to take it into consideration, and a variable angle between 42 to 26. What I use is in all these I don't measure. So what I use, I put my thumb over here and try to feel the blood pressure, and I could know if there is the artery where it's going, and I can palpate it and draw it with this. Normally, when you start, you can do this, but when you have experience, you just put the finger and you get feel it. So also, as you see that the labial artery is about 3 millimeter at the lip, with 3 millimeter depth at the border of the upper lip. So it's very important to take that into consideration. So goal of treatment is to eliminate and reverse the product, decrease swelling, increase blood flow, and increase oxygenation. So for complication, what we will be using? Nowadays, it's very important the injection. We have a lot of brands into the area which is compromised. Mainly, you don't have to put in the area exactly. You could put beside it, and the hyaluronidase will go directly to kill to eat everything when there is hyaluronic acid. Remember that the hyaluronidase are like uh, hungry zombies which are want to search for this hyaluronic acid everywhere in this area and eat it. So although it's somehow far, they will reach it. Not necessary to get directly into vessels. It works also by diffusion, and studies have shown that this may even help with non-hyaluronic acid products as Sculptra and Radiase. Also, as you see, you have to use vasodilatation product cream. I recommend the nitro paste, which is a very important vasodilatation, and some reports using prostaglandins, but not very well studied. Also, word compresses make vasodilatation and locally and are important. Then you have to use aspirin, 325 milligrams. Also, you could use low molecular height weight heparin, but there is not a lot good studies, and need to consider also medical condition before initiation. So you can also send your patient to hyperbaric oxygen cabinet, or try always to use small sharp needles and more easily enter blood vessels, whereas cannulas less smaller needles are less reliable for aspiration to check location, but also small needles have less problems, uh, more problems, I mean, when you inject, since they can go more in a vessel. So I prefer not to use sharp needles, nor to use very thin ones. I prefer to use cannulas. If I want to use any needle, I use a 31 gauge directly over the bone. So also for cannulas, remember there are round cannulas or bullet cannulas. You could use bullet cannulas for the lip, but for the other areas, I try to use rounded cannulas. And remember that there is more risk whenever it's more thin to go in a vessel. So try to use, if you want to go on safe, try to use 25 gauge. But for the other part of the face, 25 is somehow big, so I use 27. But for the lip, it's better to use a 25. So for other complication, scarring, remember that it depends where you inject, and uh, take care it in patients who have scars, because these patients can make scars from your own needles. Pain, it's variable. It can occur immediately and may not respond to analgesic, and may be absent if local anesthesia used. So know that it could happen. Blanching, and it's very important the timing. So when there's blanching, if you're not doing it as a technique, the technique blanching, what it means that I inject the filler so in the epidermis that it makes like a white area. You could do this with hydro or with other things which are skin boosters, but with some fillers like soft you can also do that, and with Belotero doesn't have any problem or Tyndall effect. So but if the blanching is from the occlusion of an artery, so blanching will be followed by the hyper secretion of blood to this area, and it will start first white then super red. So slow capillary refill is very important to do it in the face. You, whenever you think there is any problem, you press on the skin and you release the fin, and if the skin is red and you press it and becomes white and you release it, it's again red. So you know that is a good uh, capillary refill. So timing is an immediate, down on the skin for a few seconds until blanched, then release your finger and see how it should return the pink after 1 to 2 seconds. This is normal. If delayed, could be sign of vascular compromise, arterial insufficient. So livido phase, it's from 1 minute to 10 minutes. So first you start with blanching, then you will start with a livido phase, which is between 1 to 10 minutes, which means blotchy, reddish, or bluish discoloration. And it's not 100% can happen with patients who are sensitive to cold temperature. Also, the second thing is then after that it's blue and gray phase, which is timing between 10 minutes to hours and result from deoxygenated blood. So it's not reliable. It could also be a deep bruise. So you have to check that with timing and see exactly. You have to have experience that this is not a bruise. You're seeing that it's somehow more darkened than a bruise, and it happens so quickly. So for blister formation, could be between hours to days, and for demacration, also from days to weeks, with the margin of hyperemia around the zones of necrosis or skin's loss begins. And for repair and modeling, remember that this necrotic tissue skin should be taken out, and then cleaned very well with some antibiotics treatments, and the wound will start to repair itself. So when you have a complication, first you have a blanching. So if you see there is a transient obstruction by pressing over this, uh, or a fixed obstruction. So if a transient obstruction, you will see hyperemia, and then it will return to circulation, and this is somehow normal. But if you see there is a fixed obstruction, it's not coming blood to it, and it started with libido phase, then there is other signs, with other signs of ischemia. So there are a lot of protocols to treat this vascular occlusion. But when I explain now here some parts of the protocol, and finally I will finish with my protocol. So it's very important to massage and tap the area, then use hot water compresses. Days is very important to treat it directly, and nitroglycerin under occlusion 12 hours. Remember, you have to use it for the first 12 hours to 24 hours to 3 days sometimes, and heparin sometimes for 14 days. This is a protocol occlusion. They're using the nitroglycerin paste, apply immediately upon suspected necrosis, and then for 5 minutes every 1 to 2 hours. Prednisone between 20 to 40 milligrams each day for 3 to 5 days. Aspirin one under the tongue immediately and then daily. Sildenafil 50 milligrams, one per day for 3 to 5 days. Word compresses apply 5 to 10 minutes every 1 to 2 hours. And remember to avoid burning of the skin. And you can send for hyperbaric oxygen, which begin treatment daily as soon possible with continued treatment until the area is improved. So also there is a lot of other protocols like discontinue injection of uronic acid, then massage, apply warm packs, then apply nitro paste or 10 milligram of transdermal nitro patches from Novartis for a period up to 12 hours. Mix meat unit of elase like 0 to 2 with 0 to 2 milliliter of 2% of lidocaine and adrenaline, and try to inject it in the area. So inject ELIs for in 5 to 8 slots, which is the days 75 units to occluded area, and they could use hydrocortisone intravenous or dexamethasone 4 milligrams orally. So this is another protocol which you could use, but let's go for that. And the is a very good one, which I call it the eraser. So one of few things in life that we have that we can do overs. So before and after, as you see, you could eliminate all these inflammation with urinase. So what is urinase? Urinase is an enzyme protein structure of endoglycoside activity depolymerizes HA, which in humans it's identified like by 6 urinase from 1, 2, 3, 4 pH, hypal 120. So on label from 60 years of usage, it's FDA and CDER Center of Drug Research approved for hypoderma thermochlesis, which is a way to replace fluid lost subcutaneously. Patient too ill to replace by orally. So it promotes spreads of drugs and decreases absorption in patient with chemotherapeutic agent or as a local anesthetic in pain therapy. They use it subcutaneously also in contrast media or orography and as a retrobulbar anesthesia in ophthalmology. They use ironidase. So only in Europe, also to help the absorption of cutaneous hematomas, they use urinase. This is the use of urinase. So for hypodermaculasia, for chemotherapeutic agent as local anesthesia, retrobulbar anesthesia, and subcutaneous hematomas to remove them, or in contrast media for urology. But for off-label usage, we have all these from treatment of complications from injection of uronic acid or for supraglottal edema. I'm giving an example. So on label, like 60 years of experience is non-cosmetic. So off-label is for treatment of complication of uronic acid. So it's not on-label use, so it's an off-label use. So what this means off-label? So off-label means that it's not permitted by the Article 87, and as you see, the off-label prescription are always allowed and when to seek the welfare of the patient and respect their interest and autonomy. Informed consent should be written in this in the consent and to explain the patient that if you put in urinase, it's off-label. So types of urinase, we have 4 types from long-lasting classified by site of action, and I will not go in that, but we could have from animal, from sperms, from leeches and earthworm, from bacteria, and finally now they are doing more from human recombinant urinase, which is an option and it's immunogenic and safer than the others and could lead no allergies. So that's why in the consent, whenever you give a consent for injecting uridase, it should be written in the consent that it's off label and it may make allergy. That's why you inject a bit under the skin in the hand. You wait for 20 minutes, and if there is no problems, you inject in the area you want to treat. All if it's let's say that it's a big complication and you need it to do it now. So what you do is you inject with the risk of that he can have allergy to that, but you have to be prepared with cortisone if there is any reaction. So for patient who like the eyes, which a patient can come today that she's unhappy because they overdone it, you can tell her, okay, I will inject you now your days under the skin and wait for 24 hours and you come later. A few doctors do that, but this is the correct procedure. So we have 3 brands here in front of us, and it depends a lot from where they are coming. If they are from cow, from sheep, or from recombinant. Helionex is recombinant, as you see. Vitrase is from sheep testicle, and Helase from bovine testicles. So also, which is very important, is how much unit they have, so you can calculate. So for indication in aesthetic medicine, it's used in all non-emergency situations where we want to eliminate totally or partially infiltrate the hyaluronic acid. For hyaluronic acid, we have superficial implants. For overcorrection, if we have Tyndall effect, for unwanted visual effect, or for non-acute inflammatory nodule, for periorbital edema because of drainage compression or whatever, for urgent situation as ischemia, and for fibrosis. So pharmaceutical properties of this, very limited knowledge, and after intravenous injection is inactivated rapidly between 2 days, as you see in liver, kidney, and suffers renal elimination pathway. The mechanism of activation in dermis and other tissues is somehow not very known, but as you see, it inactivates rapidly. So in 2 days, it reacts and it takes all these days. Hyaluronic acid, I mean. The effect is those that type dependent by the relationship is not strictly linear. So there's a lot of involved factors in this, but not all patients the same quantity react the same. So it's very effectiveness to decrease with anti-inflammatories, and it's believed that salicylic, antihistamine, and acetylcholine treatments can increase the tissue resistance to diffusion of days. So also the activity does not diminish when mixed with local anesthesia, which is very important to know. And as contraindication, beware pregnancy, lactation, and allergy. So for Vitrace, the use is valid and effective both in early and late, and all complication evolve comparatively better if used versus not used. So no need to inject exactly where the urinic acid is. Remember that if there's an occlusion intravascular, you could spread beside it, and it will reach there. As I told you that they are hungry zombies, they want to search for urinic filler. Also, the effect varies by type of uronic acid and urinase. Remember that it depends on the cross-linking concentration and the G prime, all these stuffs. So Belotero needs a lot more urinase to 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 take out the filler. So that's why Restylane is so quicker, because the filler could be eaten very quickly and you could have less complication if you get one. This is a very nice study about studying. Let's say that if we compare Restylane, Juvederm, and Belotero, and we inject 20 units of urinidase, let's see how much the filler will take time to degrade all the hyaluronic filler. So the urinase here in 1 minute, as you see, it's still the same for 20 units, and in 5 minutes, it's mainly the same. So also with the recombinant one, the vitraces from sheep, the Linux from recombinant one, we get the same. So what we have seen from this, that with 20 units of urinase, we could solve that, and we can reduce it a bit. So, but Belotero is more resistant in this study, maintaining its shape quite well and needs more time. Restylane was the most responsive, and in 5 minutes is enough to digest than the voluma of Juvederm compared than of Belotero. So Restylane, as you know, it's from 9 months to 1 year. Juvederm from I could say from 9 months to 1 year and a half, and Belotero volume could be from 1.5 years to 2 years of filler, which can you have it in the cheeks, but that's why if there is any complication, it's better that using Restylane, because you know that it eats very quickly and you could have less problems because it can degrade quickly. Also, as we've seen that they have noted that with 20 units could be sufficient and not with 15 units. So the minimum units you have to inject in an area is 20 units. So they have seen that with 15 there is no response a lot. So also they have seen that if we inject more uridase, depends also in the filler how much co- uh, co- uh, cohesive it has, and how much cross-linked, and this makes that be resistant to urinidase. So as you see how a change between the brands. So for the incidence of allergy also, it could be something in these fillers, but remember that it's so the percentage is so near, like mainly less than 1%, but it's between 0.05 to 0.69% of course of reaction allergy. And remember that you have to be prepared with corticosteroids and treatments which could help you not get a patient to anaphylexia, and try to always be prepared for any case like this. Mainly thanks God that they are so few, widely, but it could happen, and it could be your first time, and you have to be prepared, having always a set of emergency, which I will be explaining later. So the protocol what I use is, for nodules I use 50 units of urinidase with multi-punctures of 30 gauge needle. Try to go perpendicular to the skin over the affected area, and repeat as many sessions as needed, and often between 1 to 4 weeks apart. So If there is pain and all these stuffs, I give antibiotics for 2 to 6 weeks before the urinase, and use mainly Cipro or clarithromycin, and if there is any resistance, I give others. But remember that with these patients who have pain only, you could try to use them with antibiotics and with anti-inflammatory. But if there is nodules and there are some, you see that it's a reaction, it's not an urgent one, but we want to eliminate total or partial uric acid. So with 50 units, it's maximum to eliminate all these stuffs in injecting these 50 units in multiple areas. So also there are some articles and studies have seen that in the under the eye you could inject by 75 units. You can solve the problem. The volume injected of urinase must match the estimated volume of edema. So do multiple sessions with small volumes. With this, you don't lose a lot of urinase. This is the tip. But some patient comes and they want to take it out everything. So in these cases, you go for 75 to 200 units, but with 75, it's good. As you see, the difference between this and this in 7 days. The infiltration of urinase is quick and secure, and it's the only option to take out this edema palpebral. For protocol necrosis, as you see that we could have treatment of urinase with it's an urgent situation and we want to eliminate the urinic acid and treat the skin. So there is a lot of articles, but the urinase, as you see, it's more effective in preventing necrosis if applied before 4 hours after injecting of urinic acid. So intravascular injection with or without embolization of artery compression, and a different mechanism but the same end, which is ischemia. So in these cases, if the patient starts with some pain and may sometimes be masked with anesthesia that doesn't have pain, but the skin becomes discolored, skin marble blanching, and appears an ulcer at 24 hours. This complication is rare, but the most treated one is blindness. So if you have a necrosis, okay, you can treat it and it's better than blindness. But for late application, more than 24 hours, it does not prevent necrosis but can help reduce the size if you inject urinase. And in affected zones, which is the most dangerous areas for having necrosis, is the glabella, the nasal wings, and the nasolabial folds, and the area of the lip. And the incidence is between less than, unfortunately low, but it's 0.001%. As you see in the lip, just this is anatomy patient which we got, which in an anatomy lab, you could see that the artery is so here near. So beware when you inject. But if you go with cannula, you're going in the muscle, and with the cannula, it's very hard to go in this if it's a big cannula. So as you see, the arteries where they are positioned in the lip, so that's why in the upper lip we go more in the superficial, and more in here we go in more in the anterior part. So in this area I go in here because I know, as you see, that it's in the posterior area, so I go more in here, and in this lip I go more in here down to avoid the lip problems. So as you see also how much blood we have everywhere, but thanks God that when you go with the cannula, it's very hard to inject in here, but you could go and see this in the subcutaneous. That's why if you want to inject this area, go to hit the bone, and when you hit the bone, you leave the filler. If you want to go directly with a needle, but if you're going with a cannula, you could go subcutaneously and try to leave. So for necrosis management, it's you have, so first, it's not a priority to make test of allergy. In this case, it's very low the incidence. You can go directly to the urinase. If you has a necrosis, let the patient know that you're not doing any test, but however, you should be prepared to attend event of anaphylaxis. Use a significant amount of hyaluronidase in the area between 200 units. At least between 200 units and 600 units are good, so they do not disturb those high doses before the past of 4 hours. So also you could think something which is very important, that at least
At least you need around to dilute this. You could use lidocaine and to facilitate the vasodilatation and depression. Some experts prefer to use to mix it with lidocaine, but you could use saline, and with saline it's good. You can inject directly into the area where the circulation of blood supply appears to be reduced, where the blanching or the purplish discoloration. A proper injection every 3 centimeters could be effective, and evaluate every 60 minutes. If no improvement, guided by color, you could repeat the cycle again. You could inject 200 units again, or 500 or 400, wherever you are in. And key to success is early diagnosis and immediate treatment with high dose. That's why all my patients, whenever I inject them filler, I let them send me a picture after 2-3 hours at home, and then before you sleep, another picture to the phone. And to facilitate this, you can facilitate a WhatsApp number for your office, and they can send this, and you can check them, and they are on the safe side. So then second step number 2 is apply a warm compress and massage vigorously for 5 minutes every 30 minutes. So heat promotes vascular dilatation, and this massage will help to break a focal obstruction. Apply hot compresses between 5 to 10 minutes every 30 minutes. So then you can massage typically with nitroglycerin in the area between 2 to 3 times a day, and it's very important to put immediately after the injection of the urinase when you suspect there is a necrosis, and 2-3 times a day. Okay, caution: it can cause some headaches or dizziness, let the patient know that when you're using a lot of nitroglycerin. Also, for aspirin, you have to use two capsules of 325 milligrams by day until improvement, typically for 7 days. Strictly follow the patient daily. Look for signs of improvement. With the improvement, stop nitroglycerin paste or let the couple of days as it improves the reticular pattern. Without improvement, repeat step for 2-3 days, the same thing, and then beware that you have to use your days again maybe, or continue with the aspirin regimen. Won't care if the skin is affected and the necrosis have affected a lot of the skin. You have to take appropriate hydration and cure daily and debride the necrotic skin, because it's a site for infection. So it's very important overseeing this and try to help the patient be calm, and let him understand that this could happen, and you will doing your best to improve the skin. Which the patient wants finally is the skin improvement. General supportive treatments are very important to support the patient. As you see in this case, it started with a necrosis. This is from an article between 1 day and 1 week, but 4 hours after the injection of hyaluronic acid, she presented to the clinic with lower lip problems. So when she injected the urinary, lips were pale, but most important was not given when it was introduced in the clinic was spotted. So they used 400 units of urinase injected in the lower lip, and hot compresses applied. Also, additional treatment was not performed in this case, and as you see, the improvement from day 1 to few days. So some doctors are not well prepared for these cases. When it happens, they don't know how to do. So that's why the courses are very important to learn and to be updated. So I recommend to use all these steps. Earlier I have let you know which I've been using the protocol. So what I have is a set of a protocol in case if some it happens to me. I have my set, which is the set of urgency. I could have all the materials I want to use: the nitroglycerin, the aspirin, and all these stuffs. So for blindness, take into consideration that it can happen, and because of the retrograde flow, and when you inject in this area, it could go in by pressure and go in this artery and go back to close the central retina of the artery. So all the areas which are so risky, we will be seeing them. But again, if you're injecting in the nasolabial groove, it could go also by the pressure of the syringe, go in the artery and block the artery from the back. So beware in areas like the dorsal nasal artery, which also unite to the ophthalmic artery, and this ophthalmic artery goes to the central artery, retinal artery, and
Again, the facial artery could go to the supraorbital and supratrochlear, and the nasal dorsum and the angular. So all are these arteries connected finally to finish if they go by a retrograde flow to the central retinal artery. As you see also in this anatomic dissection, the dorsal nasal artery, how it's connected by the superior ophthalmic supraorbital artery, and finally where they will go to the ophthalmic artery. The protocol, as you see that if there is blindness, uh, this is the most feared thing, and this is it could go to the central retinal artery and close. So it's an emergency, no time to send to others. Don't send to any ophthalmology or whatever. You have to treat it, and you are the one who needs to have all the time now to treat. When he go the patient to another one, you're trying not to help the patient. So as you see in clinic, there is 19% which has immediate cases. Failures reported in 2013 from 61 cases reviewed, whereas 81% are late blindness. So mainly blindness could be late, and that's why you have to ask the patient in 2-3 hours how he's seeing and how is the skin, and to send you an image and to tell you how it's going. Remember that as you see, it's so similar. If you inject the nose, the glabella and the nasolabial is around 30% of percentage to have blindness, and more in cases of autologous fat could happen, but almost never recover. And a patient who becomes blind, he may finish blind, and no successful treatment in most cases. So the movement must be restored between 60 to 90 minutes so that the retina survive. So that's why you let the patient know of anything that he starts not seeing, come to me quickly. So what they do and what things we could have to not suffer from this thing, and if in case it happens, you could have some escapatory uh, management and try to treat it and feel not so upset. So you have to treat it with 300 units to 800 units. Immediately you have to inject retrobulbar injection of 300 units to 800 units, slowly inject, slowly, never quickly. So with 25 gauge cannula in the orbit in the infratemporal quadrant until at least 2.5 centimeter of depth. This is like what we recommend. So then complement with eye massage and intravenous mannitol to quickly reduce eye pressure. So also it have seen that for prevention, slightly force the piston when injecting. Also small cannulas diameter, small syringes, and aspire something is not efficient in these areas because they will block the small ones. So always we recommend to prevent, try to inject with small amounts and know anatomy very well, and if the patient complains, stop. So remember that small cannulas diameter could be good for treating in and whenever they are non bullet ones. So also small syringes could help more because it's very hard to go in a small one in these areas. So if you will have it, you will have it, but try always to remember that using cannulas you can avoid all these complications. That's why we have shifted to using cannulas. Neuroradiology direction injection into the ophthalmic artery by retrograde cannula, massive systemic injection could be an option, but it's not studied. But you don't have time to send it to a neuroradiologist. So also, as you see, Restylane has a gel particle size about 400 micrometers, and to block the central retinal artery, which is around 160 micrometers. So or a smaller branch retinal arteries more easily than the ophthalmic artery, which is about 2 millimeter. So as you see, any size of these can block the central retinal arteries of any fillers. And the good thing that this is a cadaveric study to see, let's see where we can go with the cannula and which area of the eye to reach in the central artery and not damage. So they studied 23 pathways in cadaveric with injection routes with 25 cannula and 23 gauge needles to see what was the more reproducible to enter and more effective and with less aggressive for this area. So if you let the cannula go, it finishes in the infratemporal. So conventional injection protocol is in the infratemporal quadrant. So in this study, they have seen, let's see that if we go from the up, well, it's an effective BIA, and limited depth is around 4 to 2 centimeters, but rare tear superior ophthalmic vein could be teared, but it's protected by the muscular elevator. Also, the artery and the optic nerve, is there. So reaching at the top to the sphenoid bone, you could use that, but you could tear the ophthalmic vein. So it's an effective via, but we have better. So let's go from the medial orbital injection, and we have to avoid this area because can damage lacrimal sac and ophthalmic artery and optic nerve, and the limited depth is 3.6 centimeter. Let's see the inferior oblique injection. It's more safe, but it's very complicated technique. So let's see the inferior mid-parasagittal injection. You could have to calculate the depth, which is about 2.5 centimeter only, and it's the infratemporal fossa, and it's the safest one. So when you inject, we inject inferior lateral part. We go from here a bit, and we go in. So also for it's very safe for major structures as the vein, artery, and nerve, and can in this area could damage the lacrimal gland, but also it's also somehow safe. But again, here the cannula tends to deflect toward the center, so it's not so safe as others. So do not divert the cannula over more than 10 degrees. Always follow the bone, try to follow the bone, and it will lead you to the center of the artery. Better slow injection than rapid injection, and we have a study to demonstrate this. And remember that the orbital width is about 3.9 centimeters. As you see, if you go from the upper part of the eye, you could have the vein, which we have seen this one. You could tear the superior ophthalmic vein, and this is the superior ophthalmic vein, although it's covered by the muscle. Okay, but we recommend not to go from the upper part. So again, this is superior ophthalmic vein, and this is the muscle, and it's covered by the muscle, but you don't know, sometimes you could go in here not going over, tending to over the bone, so it can make any problem. So we recommend the to inject in the eye is the inferior mid papillae parasagittal injection, and somehow more laterally in this area. So let's see if we inject hyaluronidase slow or quick, it's better. So red is the hyaluronidase marked after injection. So as you see, when you inject slow injection in the right eye, it will diffuse a lot. But whenever you inject fast, the diffusion is not a lot. So that's why you have to inject the hyaluronidase slowly. Okay, and as you see, when you inject slow injection, see how much the hyaluronidase can go to everywhere. As I've told you, it's a zombie which is going to search for hyaluronidase, for hyaluronic acid, I mean. So let's see all these areas how we can be blocked, and what's the problem could be. If it's blocked, the ophthalmic artery occlusion, the visual prognosis is very poor to get it back. If it's the central retinal artery occlusion, also the prognosis is very poor. In a localized peripheral collateral occlusion, as you see in the image, yes, in this area you could have a good visual prognosis with the hyaluronidase. And if the branch retinal artery occlusion, as you see, it also could be a good visual prognosis. Where if it's the posterior ischemic optic neuropathy, well, in these cases, you could have poor visual prognosis. So conclusion of hyaluronidase, hyaluronidase is safe, fast, and effective tool for complication. It must have in consultation and be familiar with it as an emergency stock. Remember, it depends how much units you have. You have to calculate putting saline in it. Normally they come like a capsule in it. So you put saline, and you try to calculate how much units you have from injecting. So it's as Botox. If it's let's say that it's 100 units of hyaluronidase, I'm giving you an idea. If you have 100 units of hyaluronidase and you put 2.5 centimeters cc, I mean, of saline, you could have in this is a 100 units, and in a syringe you can get 2 syringe and a half of 1 milliliter, and every 1 milliliter would be 40 units. So with your days, you make the same mathematical solution, and it depends how many units. If you have one, let's say 100, 1500, you could put 5 centimeters and calculate how much units you have in every 0.1 cc, which could be around 30 units. So again, always consent and make always to sign the consent and let the patient know that it's an off-label. Also, it's a non-urgent complication. Try to just to inject it and v prudence and see if there is any reaction allergy. Do not subdosify. Always allergy test in non-urgent cases. Remember that I will always say it. I know the patient's coming, he's not happy because he has the eyes like that, but tell him that this is for his sake. So the uronic acid is also only the only filler on which we have tools like this. Think about patient safety and use these. So also necessary to prepare academically for treating the most feared complication, which is blindness. If you never went with a cannula and reached the cone of the eye, it's very important to make a course and learn how to go with the cannula, or try to go for any courses which they can teach you this. So for tips and tricks for prevention, use larger rounded cannulas, not bullet one. Take precaution in high risk areas as glabella and the nasolabial folds or lips. Detection is very important. Use clinical sense until later phases. Mainly, there are few complications, but if they happen, you can ruin your office. That's why you have to have a number only for these complications with WhatsApp to send you images and to confirm that they are seeing very well. Early treatment within 24 hours has great prognosis when you get any problem. So for treatment, be ready for a step-by-step treatment plan and have a crash cart, which I have like a box, which I said this is the emergency box of fillers. So you have all materials you want to use. So when it happens, you only have to think in this box, which is prepared for you. If vision changes or blindness, treat quickly and emergent as emergent ophthalmology evaluation may need it, but forget about ophthalmology. You can call him to come, but start treating you as you are the only one who can solve this, because 30 minutes in the eye, it's a lot of time. So as you also see, I should let you know, and I've said in one of my keynotes lectures, in the infraorbital nerve, there are some described cases, and it happened to me when you inject lidocaine with epinephrine, which is the anesthesia. Sometimes it can diffuse by the infraorbital nerve and make a block in the artery. So the patient will tell you, oh, in 1 second that he became blinded, till now he did not put any fillers. I'm telling you, when you're trying to put anesthesia in the infraorbital and diffuses a lot, and the patient can tell you, oh doctor, I'm not seeing from this eye. He starts feeling some fear, and remember that to calm him, it's a temporary occlusion of the epinephrine, and it could happen to you. It happened to me one time, and I was said, well, it's so strange. The medicine is reasonable. Why he should be blind? But I've checked it online, and there are some described cases. And when you inject when you inject lidocaine with epinephrine in the infraorbital nerve, it can diffuse, and the patient can suffer from a blind for 2 hours from this eye. Just I tell you this tip, if it may happen, you could know that this is normal. So advantages is that result and the downtime. Well, in fact, there is no, we can say that no downtime, but there's some inflammation in some areas more than others. And when you do with cannula, you have less inflammation. Easy technique with cannula made things more simple. Some doctors say that with cannula is more difficult. In fact, it's simplest because you can move more to all areas. You can diffuse more homogeneously. And remember that fillers, when you inject it, in this area, let's say 0.5 cc, it will not stop in this area. It will diffuse a bit in all the circumstance, giving you a nice volume area. In when in areas where there is a lot of cheek support and or fat or subcutaneous support, it will diffuse this very well. In small areas as lip, you have to be so meticulous, injecting very symmetrically, putting the same amount whenever you go back in your needle. So it's very important for repeated injections of fillers created results lasting up to 18 to 36 months, because it stimulates collagen and it takes less hyaluronic acid volume to achieve optimum correction when performing repeated treatments. Let the patient know that that's an advantage for him. So as disadvantage, it's short lasting. Also, it can only for 1 year to 2 years. It depends which brand and which in the brand the volume concentration of hyaluronic acid. But it's better to have some improvement for a year. You go for lipofilling with fat, but remember there is reabsorption rate and that surgery and there is more downtime. In fact, it's a costly treatment to afford sometimes 4 or 5 syringes for a patient to improve. But this is the only way we could do till now, till they reduce costs of hyaluronic acids. So chances of adverse reactions also could happen, and mainly remember that the patient should know that and sign the consent. And more urinase to erase Juvederm than to erase Restylane, and more urinase to erase Belotero more than Juvederm and more than Restylane, because Belotero lasts longer. So, as a conclusion, fillers have come to play an important role in non-surgical procedures, and well, it's normally a money rentability for doctors, or because you could double or triple the price, and the technique is safe, simple, and effective modality if you are properly trained. I recommend always after seeing these courses, now you could have a big idea about fillers, to hit it again and study it very well and go for a course of injection. Proper knowledge of anatomy of the area of injection and aesthetic sense and proper patient selection are very essential. So I always recommend something when I finish. I recommend Belotero for all the things which I said. There is no tendon effect. It's no lumps at all. It's very natural when you touch it. You don't see there is like a stony effect in some areas, and it lasts long. And the only thing which is worst, that if because it lasts long and it's very a lot uh, cohesive particle, so you could need more days to take it out. But also remember that if there is a complication, you need a lot more and there's more probability to occlusion. But that's why you should be trained and to be using the best product which is the best for the patient of all the things we have said. Remember also, and I will never ever let this happen, these Belotero Plus may have lidocaine, and ask your patient if he has any anesthesia problems with lidocaine or allergic problems.